Can you see my slides?
Sure. Excellent. We can see.
Okay,
Thank
Good
you.
afternoon. Okay. Thank you. Is it now on slideshow?
Yes, we can see it.
Okay. All right. Good afternoon, everybody. Thank you for staying with us this long, and thank you again to ZSGE for this opportunity to just go through this basic topic, which is just the basis of hysteroscopy. It's been a long day, but my presentation is very short and is really basic, as it says. I wish I'd spoken just after Dr. Sadens, as he gave such a lovely history of DNC and how it evolved into hysteroscopy. So I would have just done my talk then, because then most of my slides were preempted by Dr. Tim Kunojiwa, whom I hope is still with us. If he's not, well, I had actually promised the first time I'd seen him, I promised by the time we'd come back, would have set up office hysteroscopy at the University of Zimbabwe and would be going. So I hope he is listening, and I still am going to promise that soon, I think, gathering from all the discussions we've had earlier on, that soon I think we'll be on our way to the 21st century. So as an outline, I'm just going to go through an introduction, give the indications, contraindications. I'll talk a bit about the procedure, just in a stepwise fashion. And then I'll discuss a bit about a relevant anatomy for hysteroscopy. And then I'll share a few pictures or photos taken at some of our hysteroscopies, although most of them have just been diagnostic and not so much of operative. So hysteroscopy basically is minimally invasive in natural orifice intervention that is used to diagnose and treat many intrauterine and endocervical problems. We're using basically a transcervical approach using the instrument, the hysteroscope. And this was first described, as Dr. Sadens mentioned earlier, by Pantaleon in 1969. It's basically an acceptable, very convenient way of addressing most gynecological problems. It's quite accurate because you can visualize the cavity, and also cost effective, especially if we go the office way. The good thing is that it has a very quick time to recovery, and it is really a day procedure. It's a low risk technique and in the right hands, of course. So advances in technology with improvements in lenses and the use of distension media has made hysteroscopy more widespread and the test of choice to evaluate the endocervical and uterine cavity. Improved visual optics and introduction of instruments with fine diameter, less than 4 millimeters, have led to the development of office or outpatient hysteroscopy with minimum requirement for analgesia or cervical dilatation. So basically, diagnostic and operative hysteroscopy is now a standard procedure that should be offered in all gynecological practices because it's virtually quite safe and is efficacious to give us answers, therefore rendering the traditional DNC historical, or as Guja would say, dead and cremated. So these are the recent advances, as mentioned earlier in other talks. I'm not going to talk about these. The TrueClear and the Bugatti Shaver, which are just basically mechanical systems that can actually be used hysteroscopically to remove polyps, fibroids, and also remove the tissue. So what are the indications for hysteroscopy? So hysteroscopy basically is to evaluate the endocervical canal, the endometrial cavity, and the tubal ostia. And this can quickly assist you to do a site-directed biopsy or endometrial curettage to evaluate where we are suspecting endometrial pathology. And the added advantage is that it actually just combines a thorough diagnostic procedure together with treatment, where the surgeon is proficient with the different treatment modalities. So most of the women, you will agree with me, if you're doing a gynae clinic, most of the women will come with a complaint of abnormal bleeding of some sort. So this can be premenopausal or postmenopausal bleeding. And for most of these, a quick diagnostic or office hysteroscopy will give us the answers that we need. So confirmation of abnormal tests, sometimes you need to confirm an abnormal HSG, a thickened endometrial lining on scan, and you can do a scope to just see if there are any areas that are abnormal, and then you can do a directed biopsy. Sometimes there's infertility, and you can do it as an investigation to check for things like submucosal fibroids, polyps, corneal blockage and things like that. And then also in women that have recurrent pregnancy losses, we are suspecting maybe Mullerian abnormalities, uterine septum, you can also do a hysteroscopy. Some women have chronic pelvic pain, they have secondary amenorrhea, suspecting Asherman syndrome, adhesions there. That's the test of choice. And sometimes women have an IUCD where the strings are missing. I think that we discussed this earlier on. So we can do a hysteroscopy in the office to just check. Usually the strings are just curled up and you can retrieve that. And there I put a retained fetal bone. We actually had an interesting case where a lady actually had a miscarriage. 2 to 3 years down the line, she presented with dyspareunia and chronic pain. And the scan that was done was confirming that she had an IUCD in situ. And you could actually see something that looks like a copper T in the lower part of the uterus, the lower part of the uterine segment. So we convinced her that you've got a loop and the loop has to be removed. But she was adamant that I've not had a loop inserted. So we thought maybe when she had the DNC done for the miscarriage, somebody had put a loop in there, only to discover at hysteroscopy that it was actually remnants of fetal bones from that miscarriage many years back. So there I just put up that assessment by ISOG on submucosal fibroids, where you can actually see that diagnostic hysteroscopy can also just aid in assessing for fibroids, especially the submucosal ones. These ones you can assess using hysteroscopy, and you can combine this together with your 3D ultrasonography, saline contrast sonohysterography to try and map all your fibroids and decide the best modality of treatment, whether you're going to do hysteroscopic, mammectomy, laparoscopic, or whatever. And then we move on to the contraindications. So what are the contraindications of hysteroscopy? These are generally few. Just put down a few here to say sometimes we've got patients with severe medical comorbidities, for example, those ones with severe respiratory or cardiovascular compromise such that they cannot even lie on their back. I put there viable intrauterine pregnancy, definitely a contraindication. Genital tract cancer, where you have diagnosed, for example, cervical cancer, then it's not wise to then go ahead and do hysteroscopy. Of course, with this active pelvic infection, I'm going to go through some of these later on, where we're now preparing our patient for the hysteroscopy to see whether we should go ahead or not. So obviously, if the patient has got an ongoing infection, they've got purulent, foul-smelling PV discharge, then the hysteroscopy is not the best thing to do at that point. Then you can wait until they are recovered, and then you can go ahead with hysteroscopy. And then, of course, the contraindication, if you've not done hysteroscopy before, then you cannot offer it. And I'm hoping that this should fall away soon with the envisioned better training in our setting. So I put there in bold to always exclude pregnancy, especially in the younger patients. You don't want to go ahead and scope those patients and then find that they actually have an ongoing pregnancy, as in that picture there. So how do we prepare for the procedure? As with any procedure, surgical procedure, you need to obtain an informed consent. And where we're doing hysteroscopy, it's actually prudent that we also, apart from giving the patient all the information they need to do with the procedure, what to expect during the procedure, what to expect after the procedure, we have to also get a consent for possibility for laparoscopy or even laparotomy. Because sometimes you can have complications that may require you, for example, to attend to either vascular or visceral damage that can occur during the procedure, especially where there's perforation. So you need to also spell out these so that the patient can be aware of these. I remember one time we actually went there thinking it was just a lost IUCD. We went in for hysteroscopy with Dr. Nemechen, and in the posterior wall, we noted there was like a defect and the loop was not there. So we had to proceed so that we'd find where the loop was. So the loop was actually in the peritoneal cavity. So at insertion, there was actually perforation and the loop was in the abdomen, basically. So we couldn't wake up the patient to ask for consent to proceed to laparoscopy. Luckily, we managed to retrieve it laparoscopically. We didn't have to go all the way to do a laparotomy. And then we move on to evaluation. So how do we evaluate these patients? Of course, it comes out that we have to take a good history. Take a good history of that bleeding. Is it a discharge? Do they have a history of PID? Why am I mentioning these? history of previous abdominal pelvic surgery. This is important because sometimes you may find that patients may have had maybe pelvic abscess, maybe recurrent PID, and have adhesions, which may make your uterus quite immobile. So if that uterus is stuck in adhesions, either anteriorly or posteriorly, that can also increase your complication rate at hysteroscopy. At introduction, you may just perforate if the uterus is malpositioned or is not mobile. And then, of course, you'll have to go ahead and do a thorough examination from head to toe, and paying particular attention as well to the pelvic examination. We are going to check and also do a pap test as well, make sure the cervix is free of disease, offer a pregnancy test if you suspect she might be pregnant. So what time is best to do this procedure? What time is best to do this procedure? So the best time to do, if it's in a woman who is premenopausal, studies have suggested that the proliferative phase is the best time to do a diagnostic hysteroscopy. It doesn't mean that if she's in the secretory phase, you can still do it, but sometimes it can be quite active such that that thickening may sometimes appear like polyps. So the best time in a premenopausal woman may be in the proliferative phase. And for a postmenopausal woman, really any time is doable. This has been discussed quite extensively by Dr. Tim Kundojiwa, so I'm just going to go through it quickly. I just put up a slide on cervical preparation and dilation of the cervix as part of hysteroscopy. So, of course, adequate dilation of the cervix is important, but if it's stenosed and you have to dilate and you over-dilate it, then you may have difficulties retaining your fluid in the endometrial cavity if you've over-dilated. So you find that where there's difficult entry, more than 50% of, that's where most of the hysteroscopy complications actually occur, where you have difficult entry, and sometimes you create a false passage where you're trying to dilate, or you may even perforate at that point. I'm going to put up a slide later on the anatomy that will complement this point. So the dilation can actually be manual at the time of surgery. So probably this would be in our setting where our patients are under GA. Otherwise, when they are under in the office, it may be a bit uncomfortable. So preoperatively, there's talk of use of misoprostol. This has been discussed, and it has its pros and cons, and it's not for every patient. So where you think you've got cervical stenosis, maybe in the postmenopausal women, you may give them a misoprostol, just a tablet or two in the 12 to 24 hours preoperatively. And this may help you with the dilation for entry with the hysteroscope. But it also comes with these problems. You know, misoprostol can also cause a bit of pain. It can cause cramping of the uterus. It can cause nausea, even diarrhea, and fevers and chills. So you may just choose specifically for certain patients, not for all the patients. I actually forgot to ask Dr. Tim if he's using estrogen routinely for the postmenopausal women also, to try and just soften the cervix there and make it easier for entry with the rigid scope. So some would add 2 weeks of vaginal estrogen, 25 micrograms daily, just before taking the women for diagnostic hysteroscopy. Then I'm going to talk a bit about prophylactic antibiotics. These ones I'm actually guilty of over-prescribing. For all my patients that I do hysteroscopy, I'll give them a shot intraoperatively, but routinely, there's no need. There's absolutely no need. All the studies have actually shown that there's no evidence. Most of the women will not get an infection post-hysteroscopy, so there's actually no need to give any antibiotics intraoperatively or even post-operatively. The risk of infection is actually less than 1%. So hopefully I'll be able to graduate and just give them analgesia, and that is enough. And then we come to preparation for the actual procedure. Now, it's a sterile procedure, so we'd clean up a patient with iodine, typically used for vaginal preparation. And then anesthesia, I'm going to leave this because this was extensively discussed by Dr. Tim as well earlier on for the different types of analgesia and anesthesia together for hysteroscopy. So we come to the procedure itself. So of course, when your patient is ready, whether you're in the office, whether you're in theater and they're asleep, you clean, you drap your patient, you've got to empty the bladder first. So usually we just empty the bladder with that metal catheter, but there's no need to actually put an indwelling catheter unless you're doing a procedure and you think that you have to monitor intensively where you've got prolonged procedures. For example, you're doing mammectomies or basically. There's no need to keep a catheter in there, but once you're done with the procedure, you can always remove it if you needed to use it. Then after that, it's prudent that you examine your patient again. Make sure that you examine for the uterine size, examine for the position whilst your patient is relaxed. Then there's talk of the monitor. So the video monitor is not a prerequisite in all the procedures. It's actually just beneficial for the team. So the surgeon can just look through if it's just a diagnostic scope without having a video monitor. The patient is put in dorsal lithotomy position. Like I mentioned, you examine the pelvis, put your speculum, and then you can use your tenaculum to stabilize. This I'm describing for the conventional hysteroscopy. Then you grab the cervix with the tenaculum, or in our case, the vacillum, and introduce the scope under direct visualization to navigate the cervical canal. And then you can remove the speculum, because once the speculum is in your way, you still have difficulties in manipulating your scope. So you remove your speculum and then you can start your procedure. So basically that's the setup that you'd have. If you've got many monitors, you can put one directly in front of the surgeon and the other on the side for your assistant who will be looking to the other side as well. I don't know whether I should talk about this technique because I think it was described again by Dr. Tim. But anyway, this is where we should be moving towards, especially if we're going to be doing office hysteroscopy, which is basically a no-touch technique. You don't use a speculum, you don't use a tenaculum, and there's no need for anesthesia. So when I looked at the meta-analysis of 6 randomized trials, I found this technique actually had significantly lower operative pain versus the traditional technique. And the operative times were actually significantly shorter. So basically all you do is to prepare your intratus with saline or iodine, and then you can use a rigid or semi-rigid scope, but the very small diameter, if you can use the 2 millimeter, then that would work well. And then you infuse your saline at a high pressure of 150 millimeters of mercury so that you can distend the vagina and be able to see the external os. You close the labia sometimes so that you can retain the fluid within the vagina. Once you visualize your cervix, you direct your scope into the cervical canal and into the uterine cavity. So you basically start by evaluating your endocervix. Easy, as you introduce your scope, you just look through. And if you think you've seen a lesion, you can just withdraw a bit and evaluate that lesion further. Sometimes you can see polyps or whatever, and then you can evaluate and take pictures or record videos. And then we evaluate the uterine cavity. So when the scope is within the cavity, you distend the uterine cavity, allow it to distend with the fluid. You have to inspect the entire cavity. Of course, do a panoramic view where you can see the fundus, you can see both ostia, then you know that you've not missed any portion of the cavity. This may be difficult sometimes where there's extensive pathology to see all the areas, but it comes, I suppose, with experience. So make sure I identify both ostia, try and identify any pathology. So familiarize, especially when you're a beginner like some of us, to familiarize yourself with what the normal hysteroscopic what the normal cavity looks like where there's no pathology, what it looks like in the premenopausal era, what it looks like in the postmenopausal era. So when you see anything that's different from that, you can easily pick it up. Because most of the time, sometimes we do hysteroscopies and we call them negative. But sometimes I feel that we do actually miss pathology sometimes. So take pictures for documentation, and you can also always refer to these pictures later on where you can compare with other previous pictures, and you can also use the same pictures for patient counseling. So I find that in my office, I have a normal looking hysteroscope. So I use that as the baseline to explain to the patient, and then I show them how different it is from whatever findings we've found for that particular patient. So it helps as well when you're counseling the patient, so that they actually have a visual impression of of what the pathology is like, what the polyp looks like, what the fibroid looks like, where it is, so they appreciate it more. Then when you're done, try and deflate the endometrial cavity a bit and have a look again. Because sometimes when your pressure is a bit too high, you can have what we call a negative hysteroscopic view. So sometimes the lesions that are small can actually be flattened. So when you deflate it a bit, you can actually see some smaller submucosal fibroids popping up where you hadn't seen them initially with high pressures. So generally they say that 1 to 3% of benign or malignant lesions will actually be missed on hysteroscopy, although we're saying this is the gold standard. But of course, where there's focal pathology, the best, of course, is to do, without any doubt, hysteroscopically directed biopsy for that. Blind sampling, I know it has been discussed in patients, may be done where the patients have got global pathology or where they have persistent bleeding and still there's no hysteroscopic findings. So you can still do a blind sampling, get some tissue and get histological diagnosis for that. This is just a slide, just enumerating the things that we can do at operative hysteroscopy. There I just took you through the procedure of just doing hysteroscopy. So we can do polypectomy. I think somebody is going to talk about hysteroscopic polypectomies just now. Professor Bruno gave a wonderful talk on myomectomy and hysteroscopy. You can also do some procedures for abnormal uterine bleeding, endometrial ablation. You can remove the septum, sterilization. Dr. Tim did mention about the issue. Dr. Eaton as well spoke about using the hysteroscopy for emptying the uterus after a miscarriage, and of course the isthmus cell. So those are some of the things we can do with the hysteroscopy, and that's just a septum where they're dividing the septum at hysteroscopy, uterine septum there. So what are some of the operative challenges we can get? So with the cervical stenosis, especially in the postmenopausal women, we may have a challenge there to introduce the scope. Where the adhesions, like I mentioned earlier, we may have uterine malposition that can also give us a challenge at operating. Sometimes we have difficult uterine distension. For example, if you've got extensive care, I'm going to show a slide on this, a picture actually on a patient we did that at extensive intrauterine adhesions post-DNC. We may have difficult distension because the uterus is just basically clamped up in those adhesions. And of course, where there's overt uterine malignancy, the uterine cavity may be very difficult to distend and it may be very difficult to see and appreciate all those structures. To see both ostia, it may be actually impossible. Sometimes you've got patients that are bleeding excessively, so this blood can actually be obscuring your vision, especially where you're using carbon dioxide in the office setting. This bleeding may actually cause gas bubbles, and this may make it worse. So switching sometimes to fluid media will easily resolve this and you'll be able to see again. And sometimes when you're using fluid, just using the continuous flow hysteroscope allows lavage of the cavity and your vision is maintained where you can see better. So post-procedure, what do your patients require? I said you don't need, routinely there's no need, if you've just done a diagnostic hysteroscope, there's no need for antibiotics. They are okay with just paracetamol or non-steroidals are usually enough, and you may review a patient 2 to 3 weeks after. So some of the complications that can occur during the procedure mentioned already by the previous speakers, but I'll just go quickly over them. You can get a vasovagal reaction when you're trying to introduce the scope, when you're stretching the cervix, trying to dilate the cervix. You can get local anesthetic toxicity. You can get uterine perforation. I'll talk a bit about uterine perforation. You can get excessive bleeding, sometimes due to trauma on the cervix, or sometimes due to you trying to dilate the cervix. You can actually start hemorrhage there. And sometimes you can create your own false passage where the cervix is tight. And then there are also some media-related complications. These ones I discussed during another workshop. Gas embolism, fluid overload, electrolyte derangement. We will not go into details about these today. So how do you recognize a perforation when you're doing hysteroscopy? So you may realize that you've perforated sometimes where there's extension of your instrument beyond the limitation of the uterus. So you actually feel that there's a give, sometimes there's loss of resistance and there's sudden loss of vision due to uterine collapse. There may be excessive bleeding sometimes or you just start to see yellow. You start to see the omentum or the bowel, then you know you've perforated. But there's no reason to panic when this happens. You just have to wait there and see. Sometimes they're not bleeding. And remember, the scopes are so small. So sometimes that perforation is very small. So just watch. But if you're not certain, you can go ahead and do a laparoscopy to be sure that you've not damaged any other viscera or vasculature within the abdomen or pelvis. So how do we prevent perforation? Basically, if you handle your scope correctly, this reduces your chance of perforating. Allow whatever media you're using to dilate for you, sunlight, so that you can see. So always make sure that you can see where you're going. There should be continuous visualization of the canal at all times. So whenever you can't see, just do not advance the scope until you can see. And always allow the cavity to fill up completely. This way you avoid perforation. And I'm going to talk a bit about relevant anatomy. The surgeon must understand the thickness of the uterine wall around the area, especially of operation. Remember, the uterus is always thicker and longer. The younger the women, the older they are, it's thinner and shorter. So always remember this when you're doing your scope. I just put up that diagram so that it can remind us of the differences in the wall thickness around the uterus, especially where you find there's pathology in those areas and you want to operate. So you can see the uterus is about 2 centimeters thick, both anterior and posterior, but the anterior is slightly thicker than the posterior wall. And just for you to note the areas that are thin, look at those osteas, just about 5 millimeters thick. The uterine wall is very thin around the ostia and also at the area of the isthmus, at the internal os. So these are areas where you can easily perforate if you're not careful. And remember, this is not a rule of thumb. It can be different from patient to patient. So you've got to take your history and see if she's had previous surgeries before, this may be significantly altered. So this is just a table to just say exactly what I've been saying about the thickness of uterine wall. Just to remember that it's very thin at the ostia and at the isthmus, or at the level of the internal os. So these are just pictures, sorry, this picture is not quite clear. So it's just a visual picture of a normal endometrial cavity. So this is just one of the ladies we did postmenopausal. You can see that the endometrium is very atrophic. It's very pale looking. And there was no obvious pathology there, but she had a bit of bleeding, probably due to atrophic endometritis. That's the ostia that you could visualize, and the ostia on the other side as well. And there is a polyp there in the uterus. And this lady presented to us, presented to me actually 6 to 8 months ago. She delivered 2 years ago and then had retained products of conception post-delivery. So she had a DNC post-delivery. And after that, she never saw her period. So she came 2 years postpartum and she'd not seen her period at all. So I just made my diagnosis from the history that was probably Asherman syndrome. So we took her for a hysteroscopy and this is what we found. We found that you couldn't see actually anything, couldn't identify the ostia. It was just all matted in there. It was just all white, all full of adhesions. And then there is a common scenario where the patient presents and you try to retrieve the ICD that you placed 3 years ago. They want to conceive and you can't find the strings. So we took the patient, we took this lady to theater for retrieval of a lost ICD. And indeed, it was still there in situ, just the strings were curled up. But this is the added advantage of doing a hysteroscopy. You can see that whilst we're doing the evaluation of the rest of the endometrial cavity, we then bumped into submucosal fibroids. So she was already having heavy menstrual periods, and we had just said the loop is the one that was causing the heavy periods, but we then discovered she also had submucosal fibroids. So this is the beauty of hysteroscopy, that you can actually just visualize the endometrial cavity and you can see exactly what's going on. So this will be my last slide, which will just be a short video to show you just what we also encountered in a lady that presented perimenopausal with intermenstrual bleeding. She had a pap smear that said she had typical squamous cells of insignificant, undetermined significance, ascus. And upon doing an ultrasound scan, she was noted to have a thickened endometrial lining of about 39 millimeters. So we took her into theater for a diagnostic scope, and this is what we found. Forgot to mute. Anyway, so this was the endometrial cavity, and you can see how active it is. Lots of polypoid lesions, very vascular, and we couldn't identify the ostia. So the whole of the anterior wall, the lateral wall on the left side, and the posterior were all filled up with all those polypoid lesions. So we then did directed biopsies. And she turned out to actually have a grade 2 endometrioid adenocarcinoma of the endometrium. So we then referred her to gynaecologists for further care. I think that's the end of my presentation. Thank you for listening.
Thank you very much, Tarisai. We are calling for a few short questions. Any questions? If I don't see any, please remind me if I'm missing out something. But if not, I would like to move straight forward to Stewart's presentation. By the way, it looks like a Stewart's day, Karl Storz day today, as we seem to be all using Stewart's towers and instruments. Tina Shigate from PCD company, Stewart's representatives in Zimbabwe, will give us a short, hopefully interesting presentation.
Yes, I hope it's interesting.
Tinashe, yes. Okay, we do hope so. Let's see.
Yes. How are you? How is everyone doing?
Super. Looking forward to new things from Stewart's. 4D, 5D, I hope so.
Yeah, well, you'll get something interesting, that's for sure.
Okay, thank you. Let's
All right.
start.
So for those who don't know who we are PCD Diagnostics. We are the official representatives of Karl Storz in Zimbabwe and Zambia. We've been with Karl Storz for over 20 years now, and all the towers, basically a bulk of the towers, equipment, Karl Storz, everything, instruments, we supplied here in Zimbabwe. So I'm going to talk about, briefly, I'm going to talk about Karl Storz. I'm going to talk about briefly the Bugatti shaver. I'm going to show you a video clip of the use of the instruments, the equipment, and the tower. And I'm going to give you a short presentation on the cost effectiveness of it. And hopefully we'll be getting orders from this. So Karl Storz is a German company, which was formed in 1945. So they have a lot of experience. That's about, if my math is correct, about 65 years of experience. They have developed solutions all over the world, endoscopic, with instruments and equipment. They've grown over the years and ventured into different specialities. They started with endoscopy. They created flexibility in all their scopes, right? And they've got more than 15,000 products out there in the market. So without further ado, I'm going to show you a short video clip before we go into the PowerPoint presentation. And hopefully you will get a little feel of how Karl Storz equipment works. All right.
Good morning, ladies and gentlemen. Today we'll try to explain you the basic concept of fluid management, particularly focus on the intrauterine pressure. It's a very hard issue, quite complicated to explain. So I have organized for you some toys in order to better explain what I call the fluidodynamics of the instruments, together with the most recent instrumentation. So the first basic concept is that any scopes has its own characteristic. It's like us, human. We are different. We look similar, but we are different one from the other one. There is tall, there is the short one, there is the fat, the thin one. So the same thing is for the scopes. There are scopes that we are used for, like the resectoscope. There are large instruments. This one, for example, there are the internal external sheath of the 26 French resectoscopes. It's close to 9 millimeters in diameter, while we have the most recent hysteroscope. They are ranging 4 millimeters. So you see immediately the difference. It's quite high, and I give you the two examples. So there are different. So you can imagine that the fluid inside these two scopes goes in a different way. To better understand, we have a basic concept. I have a 20 ml syringe, a normal syringe, to explain to you what it means, the resistance for the fluid. That is most similar to the resistance for the electricity. So if I have the syringe is filled with the liquid, I will easily empty the syringe, if you see from the tip and my hands. Syringe has been emptied in probably 4 seconds, okay, with a certain force. If I fill in the syringe again with the same amount of liquid, but I reduce the output channel introducing the needle. So the needle is much more thinner and has a very narrow channel compared to the previous one. So now, same syringe, same amount of liquid, but reduced diameters for the output channel. And you see, I need a lot of force and a lot of time to empty the syringe. And also, if you observe the flow coming out from the tip, together with the flow coming out from the previous one, there are two different amounts of liquid. Okay, so what we have done, we have reduced the caliber, the output channel from the large one to the thin one, and everything changed in terms of pressure, in terms of flow, and in terms of amount of liquid, the output of the amount of liquid. So this is example, and it could be this example. So this is our syringe without the needle, and this is our syringe with the needle. The output channel of the resectoscope and any other, let's say, large instruments are much, much wide than the normal office hysteroscopes. So to let the fluid pass through these small diameter scopes, you need a lot of force, like the force I was putting on my finger, to push the piston and to let the liquid going out. So this is the basic concept. If you understand this basic concept, then we go into the devices to keep the pressure, the constant pressure inside the uterine cavity. So the most known one are the gravity, the bags at the gravity pressure. Probably these are the most used methods to inflow the liquid. But as you can understand, depends by the position of. So I prepared for you an example based on 2 sacks of 5 liters, same position, so they have the same level compared to the floor, but connected with 2 different silicone tubes. This is the simple silicone tubes you use for endovenous injection, and this is a typical endoscopic silicone tubes. As you can see, the diameter is different. So I will show to you what it means only to change the output tube will change the amount of liquid, the flow coming out. So if I open the endovenous system, I have a certain flow. If I open my endoscopic tubes, you see, there are two different outputs. You can see how much pressure is given on this tube only because there is much flow. Here, the pressure is acting on a larger channel, so I have less resistance for the fluid to go out, while in the endovenous system, the fluid goes much slower because the channel is much smaller inside in diameter. Okay? You can see different, but the sacs are positioned in the same level. If I will stay in this position, then it acts the second variable. So the first variable is related to the diameter of the output silicone tubes. The second variable is the amount of liquid inside the sac. If for some reason I will close the endovenous system and I let the other one going out, at a certain point we'll change the amount of liquid into the sac. Changing the amount of liquid into the sac, the gravity pressure will also change. So we will have two different flows. One generated by this amount of liquid, much more than this. And this was much more reduced. This means that at a certain point, probably if I will empty the sac connected to the large silicone tube, I will get the same flow I will be able to have using this sac filled in, connected with these thin silicone tubes. Only because the amount of liquid, the pressure, the gravity pressure on this liquid will act as an extra pressure, an extra flow. So to better explain the concept, I just empty half of the sac connected to the larger diameter silicone tube, and I left intact the other one. So now, as you can see, one is still empty, so we have 5 liters, almost 5 liters. And here probably around 2.5 liters. And watch what's happened into the flow. If you compare the previous flow, you will see that now the two flows are very similar. Why? Because gravity pressure is acting on the 5-liter sac, this one, still with the full gravity pressure. On this one is acting on not anymore of 5 liters, but on 2.5 liters. So this is an important concept. As soon as the amount of liquid decreases, if you use only gravity pressure, the gravity pressure the amount of liquid inside the sac will generate a different flow. And at the end of the story, a 5 liters bag and a 2 liters bags, they offer mostly the same amount of liquid, the same flow. This is still higher than this one, but you see much less than before. Okay. So this is the concept of when you want to use the gravity pressure. There are two main variables, the diameter of your output silicone tubes and the amount of liquid in the sac. As soon as the liquid decreases, you will get less pressure in the tube. That means less flow. Okay? So this is the concept number one. Now we move to a different idea, not anymore the gravity pressure, but the compressive cuff. Now I have prepared for you a different example. So we are moving from the gravity pressure to another very well-known method for inflating liquid inside the uterine cavity. That is the compressive cuff. Compressive cuff is a sac filled with the membrane where you put inside your liquid sac and then you compress, pumping air inside the membrane here. So this will physically compress the sac. So we have two sacs, one with the gravity pressure, still 5 liters, and the other one inside the compressive cuff of 5 liters too. The red one is the one connected to the compressive cuff. The one white is the one acting on the gravity pressure. So look what's happened, same amount of liquid. This is only with the gravity pressure. This one with the extra force. You see, I have the same silicone tube. We have the same silicone tubes, but on this one, we have only the gravity pressure, and on the red one, we have an extra force generated by the compressive cuff. So I have a much more pressure here, flow, sorry, that will generate a different pressure inside the uterine cavity. And again, here, as soon as we move on the sac, so here, as soon as the liquid will decrease inside the sac, there will be less liquid, less compression acting on the sac, and therefore less flow. So you see, that's the difference. If we use a compressive cuff, it's a variable pressure because we go back on the silicone tubes, I increase the pressure. As soon as I increase the pressure, the flow increases. This is the effect. So it's a totally manual control. There is no way to know how much pressure I'm generating inside the uterine cavity. We don't know the flow, therefore we don't know the pressure. And the pressure I'm applying on this instrument is nothing. It's just a pressure to compress the bag, the 5 liters bag inside. So now, this is the theory, the methods. So if I take the resectoscope and I connect the resectoscope to the compressive cuff, you will see a certain flow generate because this is a much larger channel, so the liquid will find less resistance to pass through the instruments. But if I change the instruments and I take remember this is the syringe, and this is the syringe with the needle. I connect the system to my office hysteroscope. Look what's happened. I have a very delicate flow. Why? Because this is the needle on the syringe. The fluid found higher resistance inside the instruments, and therefore the flow decreased. This gives you the idea how difficult it is to manage the flow and therefore the pressure inside the uterine cavity. You know that the pressure is the balance between the inflow, so the amount of liquid going inside the uterine cavity, and the aspiration, the liquid coming out. So the physical law that control these events are the Bernoulli and the Da Vinci law for the inflow, so the resistance, what I explained to you as a resistance for the fluid to pass through a channel. But it's not only, this is the inflow. Then we have the outflow. And to explain you the outflow, I have another example for you. So I took just this box, and I have 2 needles, one a thin one and another one, it's a larger one. So if I make holes, I make some holes here. I take some liquid. I put the liquid here. Nothing happen. I have like a big bubble here. The liquid stay here. Why? It's called surface tension. Okay, so the liquid stay is not able to pass through this hole. Vice versa, if I make larger holes, I fill this out again with the same amount of liquid, and you see, the liquid is passing through. What is changed? Change the surface tension. Surface tension is the law that allows the smallest mosquitoes to walk on the water surface in the lake. So here is the same example. Larger holes, less resistance, less surface tension, the liquid pass through. And this is the same concept when we move to our instrumentation. Here we have a lot of holes, you can see, a lot of holes all around the sheath of the scope, and a very large channel inside. While in the office hysteroscope, we have only 5 holes on one side and 5 holes on the other side. And the channel inside, it's a very narrow channel, very, very narrow channel, 20 times smaller than the resectoscope. So it means that if I have a certainly...
Right. I'm going to pause it there. And I want to talk about, for a minute, I would like to talk about, I'd like to talk about the 5mm office resectoscope, right? And the benefits of a 5mm resectoscope, right? So we're shifting into the PowerPoint presentation, right? So what do the experts say? The experts say that, you know, Karl Storz 5mm resectoscope, because of the small diameter, this resectoscope offers the possibility to perform resection outside of the operating room. Now, infertility patients or those suffering from abnormal bleeding can thus be treated in a doctor's office or a clinical outpatient setting, even without anesthesia. And you can use it with a tower, but since it's not very viable for you to have a tower in an office, you can actually have a small solution. I will show you at the end of it, a small solution that you can put in your rooms. So what else can I say? The minimum outer diameter is also an advantage. If you look at the benefits right here, increased safety as the current is not returned via the sheath, risk of TUR syndrome can be significantly reduced, precise cutting and initial cutting without delay. The bipolar working element can be used with all Karl Storz standard resectoscopes and sheath. That means the 7mm and the 9mm. Fully reusable system. And in addition to the 29 and the 22 size, there's also a 15, the size 15. That's the newer size, actually. And this is the size 15 resectoscope. The benefits: minimum outer diameter, as we said, doctor's office or clinical outpatient department without anesthetics, less or no dilation necessary, well, depending on the patient. And the whole system, I think you saw it in the short video that I showed you, presented by Dr. Stefano Bigatti. He's actually the creator of the Bigatti system. So this is a Hysteromat Easy. It's a irrigation system, as you can see. It came out quite recent, I would say about 2017, somewhere there. It's a new system. Barely, I don't think anyone has it yet here in Zimbabwe. We're working on it. So as you can see, it's a pressure controlled double roller pump that offers the surgeon sufficient dilation of the uterus and with continuous fluid exchange at all times. Keyword is at all times. The result is optimal viewing condition without the need for additional maneuvers at the inflow and the outflow stop clocks, allowing the operation of the surgeon to concentrate fully on intervention. So what does that mean for you, the doctor? Well, with more control in everything, it means shorter procedures. Shorter procedures means more procedures because you can fit in more in a day. And as you can see down here, the benefits, they're highlighted. And if anyone wants these presentations, brochures, please let us know in the comments, the chat section, and we'll try to email and send you some of these things. Right. In addition, this is more for the new Autocon 3400 generator. I believe only Avenues Clinic at the moment have purchased these. I think about 5 of them. This is a newer diathermy than the old one. It's high-end already, so you don't need to buy an extra resection box for the old Autocon 2400, the old one. You had to buy an extra, it was an extra charge. Everything is built in. If you can see at your left corner, right here, that's where the resection box is there, built in. And then the Bugatti shaver. The new 6.3 millimeter in diameter. That one we don't have one in Zimbabwe yet. We're hoping to get one. And there's a 5 millimeter one, which is the recommended one, but there is a 6.3 millimeter one if you want to take it a step further. Right, I'm gonna go into the setup that you can use when you are in a setting where you don't have a tower. Yes, this is the Batochi setup, the small setup. It comes with a little trolley, your telepack, a Telecom 1-chip camera, the Hysteromat Easy, the Batochi 4.3 millimeter, the 5 millimeter, a telescope, 4 millimeter Batochi, biopsy and grafting forceps, semi-rigid, scissors, tubing set for irrigation, for suction, and just the normal tubing sets. Now, this is a small setup for those who just want to do it in their rooms, or you can shift it around if you are going to institutions who do not have this this shaver with them. You can just load it up in your cars or in a small little truck, though it won't be necessary. Then you can lug it around. This is the recommended setup for those who are just doing it for themselves without an institution. With an institution, we do recommend the tower option, which is more professional and the like. Yes, for now, do we have any questions? Any questions?
Yes.
Eton?
Yes.
Eton Puma from South Africa.
Okay.
Dinasha, now you are saying now, can you comment on the difference between a 1-chip camera and a 3-chip camera? Because I think the other systems are using a 3-chip camera.
Okay. For that, I'm going to let my colleague, Mr. Chingosho, answer that one for you.
Thank you.
Hello. Good afternoon.
Hello, afternoon.
Mr. Eton Buma, thank you so much for your question. Yeah, the difference here with the 1-chip and the 3-chip camera, here we're talking about chips. Chips, the sensors that capture the images. So when you are talking about a 1-chip, we are saying we've got one, like a chip that is capturing the images. And when we talk about the 3-chip, we've got 3 chips now, which are trying to capture that same image. that the one chip is also capturing. So you can actually see the difference here, that with the 3 chip, you are getting a better image because of the resolution that we are going to capture. Talking about resolution of the picture, that's where the HD high definition comes in now. Normally, a high definition picture with a high resolution, it is something about the chips that you are talking about, the 3 chip. So a high definition can only come in 3 chip. The picture is got more resolution and it can capture more details. Like when you're talking about 720, you know, the pixels that we talk about, 720 by 820 pixels, the pixels that they talk about, that's the resolution that we calculate. When you've got a 3 chip, you get more details of the picture than a 1 chip. So that's the difference. So if you're using a 1 chip camera, yes, you can see the picture, but sometimes you see the picture is not good enough compared to the one that is a high definition with the 3 chip. It's more detailed, it's more crispy, it's more sharp. I hope your question has been answered.
Yes, no, thank you. But then the question is, why are you then, you know, putting a 1 chip camera when you want actually more clarity?
Well, the 1 chip camera is for cost effectiveness. We can actually put a 3 chip camera, but naturally a 3 chip is more expensive than a 1 chip camera.
And sorry, to answer also to add on what Tinashe is saying, why we are saying so, at times we look at, you know, when we are talking about quality, Karl Storz provide quality equipment. When we compare a Karl Storz camera, a 1 chip camera, which is a quality 1 chip camera, at times, if it was like it was face to face, I would have shown you maybe using the camera so that you see the difference of the pictures. On somebody who is not learned, who is not technical, like some of you, you won't notice much of the difference. But now when you are working in the surgery now, when you give you a good monitor and those cameras, comparing now 1 chip and 3 chip, doing a procedure, for a person who is very technical, you can tell the difference to say, here I'm not seeing the details that I'm talking about, the sharpness of the picture, you know, the clarity, even the colors. You can differentiate blood and tissues, you know, the veins, you can actually see the veins with the 3 chip. But on a 1 chip, yes, you can do an operation. Clear, you can see, but it won't be that much clearer than the 3 chip. So when we are offering a 1 chip, we are looking at the budget at the same time. With a 1 chip, you can do the procedure with a 1 chip. That one we know and we can guarantee you on that. But when it comes to somebody who is concerned about the picture quality and the sharpness and the resolution, or somebody who is doing a case like in the, who is doing neuro surgery, you see, some of the neurosurgery, you know, you need to see the veins, you need to see those accurate views. So you really need a high definition camera, which is a 3 chip or even a 4K, you know, so that you can differentiate the veins, the tissues and everything. That's why he's talking about the 1 chip and the 3 chip camera.
Thank you very much for the presentation. I just have one little correction for Tinashe. This was Stefano Betocchi of Southern Italy, would pronounce it Betocchi. And it's a Bugatti shaver. Just for a few colleagues who wanted to know what we were talking about. Professor Isaacson had a comment. Keith, did you want to say something?
No, I was just writing.
His comment was that the 1 chip is fine with the small monitor. Yeah. Please give us a comment.
Yeah, I was just saying that I agree that the cost effectiveness of having the 1 chip on the small monitors is worth it, and that you don't need the 3 chip for the small monitors that you typically use, at least for office hysteroscopy. So that was my only comment. Thank you.
Thank you very much. It means a lot to us from Professor Keith Isaacson, from our next presenter, University Professor from Harvard Medical School, Boston, Massachusetts, and Director of Minimally Invasive Gynecological Surgery and Fertility. Keith is a former AGL, American Association Gynaecologist President, and one of the pioneers in promoting and teaching minimally invasive gynae surgery in USA and worldwide. He's also a reproductive endocrinologist, special interest in operative and office hysteroscopy, and it is my absolute pleasure to introduce his lecture today. Keith has been to Zimbabwe. Welcome, Keith. Good morning.
Good morning.
How
Thank
is the
you
weather
for having
in Boston?
It's a little cloudy, but it's
Pleasure.
very nice. Thank you.
Good to hear that. So it's summer.
It's summer. That's correct.
Summer. Okay. Keith is going to give us a talk in setting up office hysteroscopy. We will definitely ask a few questions, and I'm very glad that Stewart has started with the 3-chip and 1-chip cameras. And we would love to have the best proposal from Professor Isaacson. How can we set up our office hysteroscopy in Zim cheapest and the best way? Thank you.
Okay, as I put my screen sharing on, can you
we
see
share
it?
the screen, Keith? Please.
I did already. I have it on my screen share.
Thank
Can
you.
you see it?
Yes, super.
Oh, you can see it. Good. Well, I hope to cover everything that you've asked me to cover, because I changed the presentation mostly to focus on hysteroscopy in the time of COVID, but hopefully we'll cover everything else. And I first want to thank you very much for inviting me to participate in this hysteroscopy session. And I'm very much looking forward to getting back to Zimbabwe. This was the last time I was there. And you can see that my form was not so good. So I'm looking forward to my second jump at Victoria Falls and hopefully improve upon that. My disclosures, I am a consultant for Medtronics as well as Karl Storz. And I want to thank my friend Tony Carugno, who we put together an entire webinar about 2 weeks ago, and I know Amy Garcia was part of it, about hysteroscopy in the time of COVID. So many of the slides that I'm going to show you, particularly the first half, are actually Tony Carugno's slides, and I'm using these with his permission. And the reason I show this is from Tony is actually from Miami Beach, and this was from July 19th, 2020. And you can see that, I don't know if it's the same way in Zimbabwe or in the continent of Africa, but there are a lot of people in the United States who are still not socially distancing and still not wearing their masks. And this was actually evident at the Republican National Convention when Donald Trump was giving his speech, and there were 1,500 people there without masks. So I don't think COVID is going away, unfortunately. So we want to adjust our practice to deal with it. And just as of 2 days ago, when I was looking up the effect of COVID in Zimbabwe, according to the information I can get online, there were 6,292 cases of confirmed COVID in Zimbabwe and 189 deaths. And it is felt that this may be underreported. So I think it's a problem worldwide, and I'm sure you all are facing it and dealing with it responsibly. And again, this just again showing the global confirmed cases. So I don't know where everyone is from who is on this webinar, but there's no place in the world that is free from this problem. And what has happened is our life has changed. You look at places that normally are very busy and bustling. And you can see that there's a huge difference in the way we interact every day. And that includes the effect of the coronavirus on our economy worldwide. So as a result of this, Tony Carugno put together a group of opinion leaders from around the world to come up with guidelines for safely performing office hysteroscopy in our current environment. And these guidelines were put together by and resulted in a joint statement that included several international organizations, including the AAGL, ASRM, and several others, as you see listed here. But there's good news for those of us that do hysteroscopy and are believers in it. And the good news comes as a result, again, of what you can see that were published in these guidelines. And that is that we know that COVID-19 is very risky and has proven to be airborne and is an airborne virus, but it is not seen to be in surgical smoke and blood or in vaginal fluid, which encourages us to take patients and not do hysteroscopy in the operating room under general anesthesia, particularly if the patient is being intubated, because that is a high-risk situation for COVID droplets. And as well, it utilizes a lot of the protective equipment, the PPEs that are actually needed for the other areas within the hospital. And it encourages us to do these procedures in a safe office environment where, as I'll show you, we use absolutely no anesthesia. We don't even use a paracervical block. We don't do any cervical dilation. And we perform several of the hysteroscopic procedures that I'll show you. Again, these are just data that were looked at to show us that COVID-19 was not present in the vaginal fluid. So it makes this a safe procedure to do in the office. And even if you're using the hysteroscope and you're creating the bubbles that have been mentioned a little bit earlier, these are not bubbles that are necessarily airborne. These are bubbles that come from the explosion of cells and release of steam within the cells that do not contain the virus. But again, under general anesthesia, when you look at intubation and extubation, and those are the droplets that you have to be careful of that do contain the COVID virus, but the virus is not in the bubbles from the resectoscope or the surgical smoke. So again, this just more data on the same, that we're operating in a water environment, and that these bubbles are within the cavities, and these cavities are quickly cooled down. And we do know that what's in these bubbles are, from hysteroscopy, are carbon monoxide, carbon dioxide, hydrogen ions, and these are quickly absorbed because they're very soluble into the bloodstream, and they are extubated through the lungs. So these are very safe, and they're not containing the COVID virus. So if you look at what happened to us in March when we had our lockdown, at least for many places in the United States, we had to suspend all elective surgery. We could only do emergency surgeries. And we can do surgeries in which, if we delayed the procedure, the patient's condition could worsen. So included in that group were hysteroscopic procedures. So if a patient's having very heavy vaginal bleeding and she's not responding to medical treatment, we were allowed to do those cases. If she had suspected cancer, ectopic pregnancy, retained products of conception that were not responding to medical treatment. And in our institution, we included patients who were infertile because delaying their fertility treatment would actually worsen their condition. So we were able to continue our hysteroscopic procedures, but we did it in a little bit different fashion. And the important point here is, why is hysteroscopy such a valuable procedure, is that we should not be doing these blind endometrial biopsies in patients with heavy menstrual bleeding. So no longer, if a patient comes in with heavy bleeding, do we just place a Pipelle biopsy into the uterine cavity. Now the proper procedure is to evaluate the uterus with a vaginal ultrasound, and then evaluate the uterine cavity either with an office hysteroscope, which is my preference, or with saline sonography. So having said that, and this is a slide from Attilio Despizio in Italy, we still see a reduction in our hysteroscopic procedures since COVID. It was about a 78% reduction in the clinic over in Italy. And much of that is because patients were nervous to come into a hospital setting in which they were afraid that there was a lot of COVID floating around. That in our institution is now getting back to more of a normal environment. We're seeing normal volumes. And again, these were the guidelines, and I just wanted, the general recommendations from these guidelines are fairly intuitive. I think probably all of us are abiding by these guidelines, whether they were written down or not. Certainly, if a patient tests positive for COVID, then they are not to come into the office environment until that they have quarantined for 4 days and have a negative test. We limit the number of procedures, favoring those who, again, those in which a delay could worsen their outcomes, such as cancer and heavy bleeding. We restrict access of companions. It used to be that we had a patient come into the office and she would come in with a companion, whether it's a partner or another family member, because it would help with reducing the stress, and no longer is that allowed. We do ensure proper social distancing. Everyone in the waiting room is at least 6 feet apart. The staff wears the appropriate PPE, which includes face covering as well as a mask. And we, again, unfortunately, we limit the number of team members or learners. We're at a teaching institution, and we have medical students, residents, and fellows. And unfortunately, the medical students and the residents often cannot be in the room because we are trying to limit the presence of to the essential team members. Hopefully that will change in the near future, because it has definitely impacted the education. So again, during the procedure, wear the PPE, limit the number of individuals. We don't use a lot of electrosurgery in the office. I enjoyed the talk from Karl Storz that discussed the 5mm bipolar resectoscope, and I do use that in the office, but it's used fairly infrequently. And after the procedure, we just allow the patient to recover in the procedure room. We don't use any anesthesia. We don't use any local or oral anesthesia except non-steroidals. So when a patient is completed her procedure and she's done with her cramping, which takes about 5 to 10 minutes, then she can get off the table and go back to her normal activities. We try to expedite the patient discharge so they're not in the waiting room. As we talked about, we do a follow-up. Instead of coming into the office, we do it by telephone or telemedicine. The good news is that all your disinfecting techniques for the endoscope is very, it works for and kills the COVID virus effectively. As I'll show you, we use the Cydex OPA to disinfect and sterilize our office hysteroscopes, and that is very effective against the COVID, and we did not have to change that practice. So there is clearly a new normal, but we're dealing with it, and we're getting back to normal volumes, and some of this new normal is probably good for us in the long run to begin with. So I want to go through, you've already gone through the indications for office hysteroscopy. I'm sure I'm sorry I wasn't up early enough to catch all the presentations this morning, but the indications most often in our practice is the evaluation of abnormal bleeding. I'm an infertility specialist, so all of my patients prior to going through IVF get their cavity evaluated. I've heard you discuss the location of lost IUDs and IUD strings. We use it to identify focal endometrial cancers, and we also use it in the office for retained products of conception. Almost all of our patients who have postmenopausal bleeding will get a pipelle biopsy, and if the pipelle biopsy does not explain the cause of the bleeding, then we will do an office hysteroscopy to look for focal lesions. And I'll talk a little bit about doing the minor surgical procedures in the office. And these surgical procedures include visually directed biopsy, polypectomy, myomectomy, lysis of adhesions, metroplasty, and placement of tubal occlusion devices in the past, but now that's off the market. The equipment that's necessary is fairly minimal. If you're doing just diagnostic procedures, you could use either a flexible or a rigid instrument. If you're doing some of these procedures, you're going to want a rigid continuous flow hysteroscope, which is somewhere between 4.5 and 5 millimeters in outer diameter, and we'll go through the operative instruments. We do use a little cart, but that Portapack that was shown by Karl Storz is also a wonderful technology. But if it's many times the operating room will be upgrading their equipment, they'll have an old monitor and light source and camera that you can utilize in your office and keep this to a minimal expense. So just to do a diagnostic hysteroscope, again, you can use a rigid 3 millimeter non-continuous flow, a flexible scope, and some of you may be familiar with some of the newer digital technologies, such as the EndoC or the Lenascope. The disadvantage to this is that it's fairly expensive per use. It costs in the United States over $200 per use, where these particular instruments you can use over and over again for 20 years, and it's somewhat less expensive. Now, as opposed to the Dragana, I do call them Batoki. I don't call them Batachi. But opposed to the Batoki scope, I use this Karl Storz scope for the following reasons. When you use the Batoki scope, if you saw when he put in the instrument, he put his instrument in through the inflow channel. And then what you're doing when you put your instrument through the inflow channel is that you're obstructing the fluid going into the inflow channel. And that's why you need a pump when you use his system. When you use this Karl Storz system, you have an inflow and outflow, and the working channel is actually the outflow channel. So that when you put an instrument in, you're not obstructing your inflow and you can maintain distension. And with this particular system, though I'm a big believer in pumps for other reasons, you don't need to have that same easy pump that you do that was described on the Batoki system. So this is my instrument of choice for the office. And most of the time I'm just using 5 French instruments. These are reusable. I often just use the blunt tip scissors, the graspers, and occasionally I'll use the sharp scissors. There are other instruments that you heard about. Again, the morcellators. I don't find a lot of indication for the morcellators. These that you see here are very expensive. But again, I do like the 5 French resectoscope, and I hope to show you a procedure using that. I personally like to use this drape system to collect the fluid for a couple of reasons. One, it collects the fluid that comes out from under the patient. It also collects the fluid that comes out through the hysteroscope. It's relatively inexpensive, at least in the United States. It costs around $20. I'm sure you could do less expensive, but the most important thing for me is that you can just throw this whole thing away when you're done, put a new one on, and if you're doing a lot of these in the office, within 10 minutes you can have the room ready for the next patient, because there's no fluid on the floor, there's nothing to clean up, and it just helps with our efficiency. Again, for fluid management, also with that particular system, it comes with inflow tubing and outflow tubing. So you get your inflow tubing, outflow tubing collection system all for around $20, and it's now available through Karl Storz. So again, most of the time you'll do fine depending on the system that you use, but with this particular scope, you'll get adequate distension either with just a gravity hanging a bag or using a pressure bag, and you're only going to use saline in the office. There's no reason to use any monopolar electricity, and there's no reason to ever use electrolyte-free media. Again, this is an old tower that's relatively inexpensive, and as you can see, we don't have a special procedure room. This is their new porta-pack, but we don't have a special procedure room. We use a regular exam room, as I show you here. And in that regular exam room, we just roll this tower in. So the same room that I do pap smears and wellness exams with, I'll do the office hysteroscopy. So nothing more is needed. So, and I think what's helped office hysteroscopy is that we no longer utilize this standard approach where we put in a speculum, put in a paracervical block, put a tenaculum on, pull the uterus down to put in a hysteroscope. And this causes discomfort. It causes discomfort when you put in the speculum. It causes discomfort when you put in the paracervical, and it causes discomfort when you pull on the uterus. So now almost all of us, and you're probably doing the same, are using the vaginoscopic technique that was introduced by Potocki and his group back in the mid-1990s. So it's amazing how little stress is induced when if you're in the office, the patient's fully awake, and all you do is put the scope into the vagina and distend the vagina with saline, and then pull the scope back and insert it into the uterus. It does take some practice if you're not doing it already, and the practice should be done in the operating room, not while the patient's awake. But after you do 5 to 10 procedures in the operating room, you'll be very adept at this. And I think this in itself has really helped us as far as being able to do these procedures in the office without any anesthesia. And this is just a diagnostic hysteroscopy. I'll show you a little video. These are all unedited videos. And this is just a vaginoscopic approach using the rigid hysteroscope. The reason this was done was a patient who had infertility, and they had a little bit of trouble getting the transfer catheter through the cervix into the uterus. So we looked to see if there were any problems. Again, we're using no tenaculum, no paracervical block, no dilation. And you can see that there was a little bit of filmy scar tissue in the cervical canal, and that probably is what made it difficult to get the catheter into the uterus. And once you're in the uterine cavity, you want to make sure you identify both tubal ostium, and you can see that here. And that's all it takes to do the hysteroscope, and it's really less than, I think at this point it is less than, it's 1 minute and 11 seconds to do the entire procedure. So we also do visually directed biopsies, polypectomies, myomectomies. I do almost all of my Asherman's cases in the office. We'll do some septum repairs, and I'll show you a few of those. If you're going to do a polypectomy in the office, this is what I would start with, this one, because it's so simple. Again, the patient is wide awake. There's no paracervical block. We're talking to the patient as we're doing this, and there's absolutely no reason to put in an expensive shaver into this particular patient. All you need are the blunt tip scissors or sharp scissors, and you want to cut the polyp off at the base. And then once you do that, the second instrument that you'll see here coming in is a 5 French tenaculum that's also reusable. And this is the tenaculum. Grab the polyp. And then take it out. So again, that polypectomy in the office took, it's 1 minute and 5 seconds. And there's absolutely no reason to take that patient to the operating room, and there's no reason to use any expensive equipment to shave that polyp down. That's about as easy as it gets. We do some myomectomies in the office. These are not fibroids that cause heavy uterine bleeding. These are fibroids that are there in patients in whom they have infertility, and you don't want, if they have a type 0 myoma in there, you don't really want to put an embryo in that cavity. So we'll attempt to do these in the office. And again, this is vaginoscopic, no anesthesia. You'll hear us talking to the patient, and you look at this, and this is a fibroid in there, and you're saying, it's so tempting to get this out, and all I have to do, look at both ostium, is disconnect this fibroid from the myometrium with the scissors. And I'm going to fast forward this a little bit. So again, we're not using any energy. And the reason I feel comfortable doing this in the office is that, let's say worst case scenario, I did perforate with these 5 French scissors. These are 1.5 millimeters in outer diameter. They're not using any energy. Therefore, I wouldn't have to take the patient to the operating room to look for a bowel injury if I perforated with this small instrument. So it's not something I want to do, but it adds to my level of confidence. So once I've detached this, I go back with that tenaculum. And then this was the hard part, because this actually was too big to get out through the cervix. I'm not going to show you my 10 minutes of frustration trying to get this out through the cervix. So what I did was I left this in the uterine cavity, had the patient come back a week later, and then it turns out she expelled it on her own. So we were fortunate. But if I were to do this same case now, I would use that 5 millimeter shaver, the resectoscope, to get that down. This is the resectoscope. Again, understand I'm using this 5 millimeter resectoscope, again, using the vaginoscopic approach. We're not using any anesthesia. Even with that, if you cut the fibroid or a polyp with this loop, you won't, it's not painful. However, if you touch the myometrium with the loop, it is painful. So you just have to be careful using it. Also, if you are using this instrument, beware that this loop is very fragile and you cannot use it really to massage tissue like you can the larger loops. But again, this is being done in the office with no anesthesia. And the goal when you remove a fibroid, no matter where you're doing it, is to remove 100% of the fibroid. Do not remove 75% of a fibroid and expect it to just, the rest of it just to disappear. So if I can't remove the entire fibroid using this technique, I'll use another technique. But this one we were able to get the entire fibroid out in the office just using that little 5mm resectoscope. And I just want to show you toward the end of it. We're at 2. Yeah, that's all of us just talking to the patient. She's doing fine. Yeah, so we're moving the entire fibroid, as you can see there, all the way, including the muscle attachment. And again, we're at 2 minutes and 46 seconds. We do a lot of patients with Asherman's in the office. When I do a patient with Asherman's, I'll start off with a 3D ultrasound to try to assess how much of the cavity I think is involved in scar tissue and how much is going to be normal. And then we'll actually do all the Asherman's. All the Asherman's we do is with a blunt tip scissor. We do not use any electricity or any heat when we take down the scar tissue. So we just do this again, just with the blunt tip scissors. And we do this when the patient is wide awake. The nice thing about the patient being awake with Asherman's is often you can't tell if you're cutting scar tissue or if you're creating a false passage. But when you create a false passage, it's very uncomfortable for the patient. So she will let you know that you're in the wrong place. I'm just going to fast forward this so you can see, what we're doing. And then once we get inside, we identify the tubal ostium. So we know we got to the top and we went through all that scar tissue. Actually, it's here. So that's we got back to what appears to be a normal appearing cavity. And with each one of these hysteroscopes, you want to make sure you see both tubal ostium, which you can see on both sides. That's the only way you know you got all the pathology. Visually directed biopsy, I'm just going to briefly go through this. This is a patient who had postmenopausal bleeding. A pipelle biopsy for some reason came back tissue insufficient for diagnosis. So we put the hysteroscope in. And then once inside, you could see a lesion that was not picked up with the pipelle biopsy. So we take a big section of this lesion with scissors. Grab that lesion with either a grasper or a tenaculum. And then we have a large section of tissue to come out to send to pathology. And that came back as grade 1 adenocarcinoma. And lastly, I'm just going to show you, again, we do the we do the septums in the office. Same thing, it's a very narrow septum. We just go in with the scissors and we'll just take that down. Again, it doesn't hurt until you get to normal myometrium. And that's all there is to it. So this is at exactly 3 minutes to take this down. So we don't do much in the office that, and we'll also do retained products of conception. We don't do much in the office that takes any longer than 10 minutes. That's really a long time for a patient to undergo a hysteroscopy without any type of anesthesia. So in the office, most of our procedures are 10 minutes or less. And this is just going in and visually piecemealing out the retained products of conception until we get the whole thing out. So again, it can be done easily in the office without going to the OR. So we talked about, someone mentioned complications earlier. Fortunately, the risk of complications is fairly small, but what you want to do is make sure that if you have a complication, that you can easily handle it. So we actually have this crisis checklist that we borrowed from the operating room, because some of it is pertinent for the office. So for example, if you have a patient who has a severe vagal response in the office, or she has an allergic reaction to one of the medications that you gave her, first thing you want to do is to recognize it. So you're looking for hypotension, bronchospasm, and what have you. And then you just go through this checklist and you call for help. You do everything here. And then when it starts talking about giving medications, you don't have to memorize the dose of the medications. The drug doses are all right here. So this is what happens. It's not that uncommon for us to get a vagal response. So we do have the atropine in the office. And again, it's just, you can see the dosage is right there. And actually, Karl Storz has a modified version of this checklist that I helped them create about a year ago. So if you talk to your Karl Storz rep, you should be able to get that checklist if you're doing office hysteroscopy. If you are using local anesthesia, this is a great chart to have in your office so that you have the maximum dose in milligrams per kilogram that you bring into the exam room, so you'll never overdose the patient with local anesthetic. Again, the way we take care of our scopes is that we wash them with this enzymatic soap, and then we soak them in the Cydex OPA, which does not give off fumes. And that has been approved by our infectious disease department at Mass General Hospital and Newton Wellesley Hospital. And to knock on wood, to my knowledge, in the last 30 years, we haven't had a known infection, and we do not give any prophylactic antibiotics. So you do have to just keep a logbook. So in summary, thank you for your attention. I look forward to getting back to Zimbabwe as soon as I can. And I appreciate being invited to speak with you this morning. Thank you.
Thank you, Keith, very much. We are really honored to have you here as a speaker. We wish that we could have organized something like this in real life, and we are hoping that once this COVID-19 has decreased, that we could have you here as a speaker and as a surgeon, and obviously back to Vic Falls for another challenge. Do we have any questions? Maybe I don't see. Some colleagues can just start talking if I don't see. I have one little comment in the meantime. Cooper Surgical has a lovely gadget that's Endo-C, and I did try in several occasions to buy the product from them in Washington at AGL directly, and they would not sell Endo-C outside of US. So eventually I ended up getting, I know this is all about Karl Storz today, but I will make one little digression. I managed to get ProSurge from San Francisco, from Ashwin Desai. It worked very well. We could do flexible cystoscopies and flexible hysteroscopies, which was a bit of a challenge, but flexible office hysteroscopies was magic. Issue, no working channel, proper working channel. So I couldn't really, I could just take a specimen out and take few biopsies. The issue with us here with office hysteroscopy is medical aids are very unsupportive. The cost of initial equipment would be circa $40,000. And a number of colleagues are hesitant to go that route as medical aids are not recognizing office hysteroscopy as an independent procedure. So the moment you write hysteroscopy, that is considered as OR, anesthetist, hospital, and those are the only claims that you can see on the claim list. Government hospitals, on the other hand side, are battling with a difficult economic situation, and hysteroscopy is usually left behind as an office hysteroscopy procedure. So those are our issues, and I think we are slightly backward. We are trying, and we are negotiating with Storz. I think they will have a little bit more ear for us after today. They seem to be very positive, but we are talking to them to assist us in terms of supplying equipment for the office hysteroscopy.
I hear this quite a bit. This is the same problem in many countries around the world where the government is not supporting the ability to do these procedures in the office. And I don't understand it, only because it's such a cost saver for the entire healthcare system that you can do it in a low cost environment. You can do it quickly. The patient is back to work. There's minimum inconvenience for the patient. They come in the morning and they're back to work in their normal activities within an hour after the procedure. And you have none of the expenses of the operating room, like you said, anesthesia, and taking up the resources for the OR that should be used for more complicated cases. So other than it takes a long time for change. It makes so much sense to do these in the office that I encourage you to keep the battle going. Keep the battle going, because it's very rewarding for the surgeon to be able to do this in your office in a case that you would ordinarily have a patient go to sleep for. And it's much more efficient for your office because you're not going to the OR with your waiting times and what have you. So once it happens, I think you'll really enjoy the procedure and find it very gratifying.
Thank you very much. We have another participant, Dr. Felix Matlanga. Raise the hand. Felix, please unmute.
Well, thank you. Keith, thanks for the inspiring presentation. I just want to get a comment from you along a similar discussion that we had earlier on. What are your thoughts on when are you doing the PPL in the States versus office hysteroscopy? I ask this because I'm aware you're in a very highly litigious environment where you work. And I wanted to be clear about what is the protocol for someone you're investigating for abnormal bleeding, and you have access to both the PPL and the office hysteroscopy and even the theater one. What's the approach like in your setting?
So in our setting, it depends on the definition of abnormal uterine bleeding. So it would be different for a postmenopausal person than someone who is premenopausal, who is having regular cycles but very heavy. So both of those are abnormal, but they would be handled differently. So let's take the patient who's postmenopausal bleeding. Her initial evaluation will include a vaginal probe ultrasound to look at the endometrial echo and the thickness of this endometrial echo. If it's above 5 millimeters or above, then she will have a pipelle biopsy. The pipelle, if it's negative, then the next, and she continues to bleed, the next step is to look and to evaluate the cavity either with a saline sonogram or with a hysteroscope. And that can be done in the office, and it can be done in the operating room if the patient doesn't tolerate the office procedure. So it's the same evaluation, and it's there's no one that's dictating where that procedure, where that evaluation has to occur. It just should be, it just should occur the same way in each patient. Same, now take the patient who's 35-year-old having regular cycles, but hemorrhaging. And then you do a vaginal probe ultrasound, you see a fibroid, but you can't tell if it's a type 0, 1, or 2 just by vaginal probe ultrasound. So either you do an office hysteroscopy to look at it, or you can do a saline sonogram. Either one will help you assess whether it's a type 1, 2, or 3 fibroid. And then you can decide at that point whether it's something you can manage in the office or, again, treat in the operating room. So actually, none of this has to do with litigation. And fortunately, I'm sure it'll happen next week, but unfortunately, in my 30 years, I haven't been sued yet. So it has nothing to do with the attorneys. It's really what's in the patient's best interest.
Yeah, thanks for that clarification. We earlier on had a discussion. I mean, it was basically saying we were trying to tease out whether it's really, on one side we've got science, on the other side we've got cost, and we're trying to see what is this driven by. But I'm happy to notice that even in highly resourced countries, it's probably not worthwhile to start with hysteroscopy when you can easily get a diagnosis from, say, a PPL, correct?
If you can get your diagnosis from a pipelle for postmenopausal bleeding, right? If you, I mean, they should all have an ultrasound, we feel, to assess the ovaries, the uterus, and the endometrial stripe. And then if you get the diagnosis with a pipelle, they don't need an office hysteroscopy. If it's a cancer, right, you know what to do. But there's a large percentage of these in which it's a focal lesion, like I showed you before, where they had a cancer, but it didn't show up on a pipelle. And in that case, some type of cavity evaluation is necessary. My preference is the office hysteroscope, but either because I can get the biopsy with it, like I showed you.
Thank you.
Thank you very much, Keith. Any other? Thank you, Dr. Matlanga. Any other burning questions? Once again, we are expecting you in Zimbabwe shortly, and I hope we will stay in touch. Wish you all the best, and thank you very much for this afternoon.
Thank you.
For participants who are just joined, we are running afternoon session of ZSGE seminar on hysteroscopy. We have participants from New Zealand, and it's past midnight there, and they are quite tired. We have participants and presenters from USA, from Europe. I saw Portugal previously, South Africa, Zimbabwe. And it is my absolute pleasure to introduce Amy Garcia. Amy is a clinical assistant professor in the Department of Obstetrics and Gynecology at New Mexico Health Sciences Center in Albuquerque, Mexico, New Mexico. Dr. Garcia is past board member of AGL and is current member of advisory board, with actively serving in several committees as well as past chair of postgraduate courses of AGL and American College of ONG. She serves as reviewer of JMIG, my favorite journal, and that's a journal of minimally invasive gynecology. Amy, good morning to you. How have you been?
Good morning.
Good morning.
I'm good here. Thank you.
How is the weather? How is the weather?
So in New Mexico, we're a high desert, and so our temperature is about 90 degrees Fahrenheit and sunny.
Lovely to hear that.
Yeah.
We currently have a similar weather here. It's quite dry, and this is the time of the year when our summer begins. And it's really beautiful. And it is a gorgeous country with very nice people and very beautiful scenery and wildlife. We would love to have you here. I know that you haven't been to Zim before. And we do hope then by next year we will have pleasure to host you.
Yes, I would like to come with Keith so that I can bungee jump with him.
Yes, absolutely. At that time when he was here, we did not have an opportunity. We were rushing all of us to Cape Town for minimally invasive conference, but I do hope by next year he will have opportunity to come and see Harare.
Great.
Amy, you promised us a beautiful presentation today. I look forward to it.
Great, I'm trying
Can
to
you
share
Yes.
my screen.
While Amy is trying to share the screen, we are aware that presenters are from different countries and different time zones, and that there was some repetitions due to the overlapping of various topics. But it also brought some flavor to this meeting, as we could hear how experts from all over the world solve similar medical conditions, instruments that they use. I was really impressed that Keith actually did not use Bugatti shaver to remove all those polyps and even office myomectomy. So we can always learn something on the same topic from a different presenter.
So Jogana, do you see my full screen or do you see something else up there? Do you see the presentation?
I see just you.
No presentation?
No presentation?
Yeah, it's saying that it's, yes.
MacBook. So you must go into share presentation, and then we had one colleague previously, he went into the Microsoft. Let me see.
So when I do share presentation, I should do share screen.
Share screen, yeah.
And I choose the Microsoft PowerPoint, and then I share. Here we go.
And it's there. Here we go. Yeah.
There we go.
We debated with one colleague for half an hour. So good.
Well,
we learned something.
You figured it out for me.
No, from the previous presenter. No.
Yeah. Well, you worked it out for me. So
it worked for you. Yeah.
Thank you. I hope to share some videos. So I hope those do come across for you. And my disclosure is I am also a speaker for Karl Storz. I consult for a company here in the US around hysteroscopy. What I would like to do first is to spend a little bit of time on the physics of the hysteroscope and the lens, so that as I speak about polypectomy and show some what I hope are very practical techniques to polypectomy, it makes a lot more sense by first understanding the hysteroscope. And Dr. Isaacson, it's always a pleasure to see him present. He has made his procedures look very, very easy. So my goal is to teach you some techniques to make your surgeries look like his. And first, that is really about mastering the hysteroscope, because there are a number of components that really must be understood in order to, I think, really facilitate these procedures. And what I am presenting is all done in the office and not in the operating room, which also becomes important when having an awake patient, is to really understand the mechanics of the hysteroscope. And that is where the lens is in your visual field, the lens angle that you're using, and what visual field it creates. being very mindful of the camera head itself, and once an operative instrument is brought into the visual field, really understanding the instrument and lens relationship. And comparing our 0-degree operative hysteroscopes and or diagnostic scopes, most of the diagnostic lenses are 0-degree. The visual field that's created is really quite narrow. And the way you'll know this is simply by rotating the camera about that midpoint axis, the visual field doesn't change. When we add a forward oblique angle, and so for most operative hysteroscopes, they're 12 or 30 degrees, the operative field that we get now with this forward oblique lens is greater. So we're able to see much more within our visual field than simply with that 0-degree lens. The important thing about a forward oblique lens, and perhaps you know this, and this pertains also to a laparoscope, but is that the light post is affixed to the hysteroscope actually opposite to the lens angle. So this is a very, very important relationship to understand as we move forward into understanding how to bring an operative instrument in and use it effectively. And what happens with this forward oblique lens? Well, it does create an offset visual field below the horizontal plane. So if the light post is up, then the lens will be looking down, and we will see the majority of our visual field below that horizontal plane. If the opposite then is true, if we just simply rotate the light post down, then the majority of our visual field will be above that visual plane. This becomes absolutely critical to doing the vaginoscopic procedures that Keith is talking about. It is much easier to do a vaginoscopy with a forward oblique lens than it is with a 0-degree lens. It can be done with the 0, but you can see that if I place the camera into the vaginal fornix and I'm looking up, I'm much more likely to be able to find the cervical os. It also becomes very important to navigating the cervical canal with the forward oblique angle. If you are used to using a 0-degree lens, this upper panel on the left, this is what you see, and this is what your brain tries to recreate once you get a forward oblique lens into your hands. That bottom panel shows you, well, what is the actual visual field I should be seeing in order to have that hysteroscopy parallel with the cervical canal, cause much less cervical trauma, much less discomfort with an awake patient. So if this is not familiar to you, it becomes really imperative to get your brain to switch to understanding this 30-degree or 12-degree offset visual field. What does this look like within the cervix? On the left, this is within the cervical canal. The lens is looking up. The majority of my visual field is above the horizontal plane, and it correlates to that panel in the middle there. We are given a clue about our visual field, and it's this here. So let's look at this magnified. This little notch is called a reticle, and the location of the reticle actually gives us an important clue about where the light post is. The reticle is an indicator of the location of the light post. The fact that the reticle is pointing up also will give us another clue. So the first is the location. The light post is down, the reticle is at the 6 o'clock position. As this light post rotates, the reticle will rotate. And then the fact that the reticle is pointing upward will tell you the direction of the lens angle. So putting both of these components together, the light post is opposite the lens angle. Light post and reticle are the same indicator. So your reticle will tell you which way your lens is looking if you simply look at the direction of the reticle. This becomes really, really important when you don't have a landmark such as a tubal ostium or being within the cervical canal. You'll always know which direction you're looking by identifying the reticle and then knowing that that indicates where the light post is and that you will be looking in the direction of the apex of that reticle. When we bring an operative instrument into our visual field, we just need to be mindful of the differences of our view. So the tissue removal devices are using 0-degree lenses. And the reason they do that is because those long instruments are entering the hysteroscope from the back of the camera. So those are generally proprietary offset lens hysteroscopes. So the lens is set off at an angle to allow the instrument to come through the back. And these work fine, just understanding that there is a more narrow visual field compared to the offset visual field that we get with a 30 or 12-degree for oblique lens. What this means when we've got an offset lens is that the lens will always, always, always be looking at the operative instrument. And why? This is because the operative channel will be set
Amy, I think you muted yourself. Can you please unmute?
Also note that the extension of my operative instrument is really much closer to my lens. So
It's muted again.
am I muted?
Now it's okay.
You know, let me take my earpieces out. Maybe this is causing a problem. Can you hear me?
Yes, it's working.
Okay. Was I muted at some point during that time?
Yes. So if we can start this slide from the beginning, I think it will be better. We have time. Yeah, thank you.
Okay. Okay. So this slide is meant to represent the difference between the 0-degree lens and having a 4 oblique angle, whether this is a 12 or a 30-degree lens. Because in this upper panel with a 0-degree lens, the visual field is just more narrow. And so the tissue removal devices will all use a 0-degree lens. And the reason they use a 0-degree lens is that it's hard to get an offset oblique lens angle with the hysteroscopes that have an offset eyepiece. And so there's a 0-degree lens at the tip, the instrument comes into the back. So these instruments are fine and you can actually see your instrument very well. It's just within a more narrow visual field compared to using a 30-degree lens. The light post is up, the lens is looking down, but this is an indicator that the lens will always be looking at the operative instrument. And this is because essentially the dynamics of the physics of the hysteroscope, how it's been set up, the lens will always be looking to the operative channel because the operative channel is below the lens. This does become important because understanding the instrument as it comes into the visual field, the more you can understand it, the more you can manipulate the lens and the operative instrument to your advantage when doing a polypectomy or removing any tissue or just simply using an operative instrument. One thing to note with the 0-degree lens is that the instrument must be extended much further from the hysteroscope in order to see the entire instrument in the visual field. And it's just, again, to be mindful of it because you don't want to extend too far into the uterine wall. With a 30-degree lens, the instrument doesn't have to be extended as much because you can actually see more of the pathology with an angled lens than you can with the 0-degree lens. So there's an advantage of the visual field that's created with this 4 oblique lens. So let me take us through this. So this is tissue on the anterior uterine wall. And the instrument, the hysteroscope, will be parallel to the uterine wall, but perpendicular to the base of the pathology. Notice where the reticle is. That's the small white arrow at about the 5 o'clock position. This is looking up. This is an indicator that the cat, and I hope this doesn't get too redundant, but I do think it's important to understand. So the light post is down. This is an indicator that my lens is looking up. Also, the point of the reticle is upward. So I know from the physics of the hysteroscope, the way it's set up and the lens, I know where my operative instrument will enter the visual field, and it will be directly opposite of the reticle because the lens is always looking at the operative instrument. So now as I bring the instrument into the visual field, the hysteroscope and the instrument are parallel to the uterine wall. The instrument comes in opposite the reticle. And now I can approach the tissue perpendicular at the base. And once, and this may be very intuitive to you if you've done a lot of operative procedures, but as we move the instrument in the visual field, we're actually moving the entire hysteroscope with the instrument as one tool. Let's look at this again. So here is a polyp attached to the left uterine wall. The reticle is indicating where the light post is. So here I am looking to the patient's right. If I bring my instrument into the visual field, then the angle of approach isn't the most ideal to transect this polyp because I actually want my instrument to transect perpendicular to the base. So I need to bring my instrument parallel to the uterine wall and allow my instrument to be perpendicular to the base and not vice versa. So I need to rotate my lens. And so I'm going to take my light post and I'm going to watch the blue line and the reticle as it moves, and the instrument angle moves as well. So now I can fully rotate my lens, and that brings my operative instrument to the place that I have the best access, which means more efficient use of my instrument in an awake patient, and I can get this procedure done much quicker with less struggle. So it's really just being aware of these components will make your polypectomies more efficient and ultimately, I think, better for the patient. Again, we move the instrument together as one tool. One more visual field comment, which is that it's very easy to get distracted with what is on the monitor and forget the fact that there is another component that creates a visual field, and that is our camera head position. And so the camera head really must remain in an anterior and posterior direction. The camera heads do allow themselves to not affix entirely to the eyepiece of the hysteroscope, meaning that you can move the hysteroscope without moving the eyepiece. If your eyepiece is affixed and you start to really rotate the entire hysteroscope, well, what happens is that the camera head will move. And so what you see is this on the monitor. However, that is not actually your visual field. The visual field, the uterus anatomy didn't change, just your visual field did. So if you're not aware of your camera head position, then you lose, essentially, potentially lose your bearings and your orientation within the uterine cavity. So just be very mindful of your camera head. These are the instruments that I use. These are the workhorses that I use. I use a sharp scissor. Keith actually got me excited about that tenaculum. I love this instrument. It's so useful to so much of what I do. And I use a dull scissor as well as basically a grasper. So they're semi-rigid. They're either single action where both arms of the instrument open. This gives a wider girth to what you're able to grab versus a single action, and most of the scissors will be single action, protects the mechanism of the blade. So some considerations for polypectomy outside of the hysteroscope. So these are really the morphologic characteristics of the polyp that you need to keep in mind as you're approaching how to remove this tissue. So the type of attachment will make a difference. It's sessile, it's going to be much more difficult than something that's pedunculated. the location within the uterine cavity also makes a difference in how you approach the tissue and how difficult it is to remove. The larger the polyp is, the more difficult it is to remove, or it takes a longer period of time to get it out. The tissue density, there's a very wide range of tissue densities. I had a polyp once that came back as osseous calcification, literally bone. Some are very soft, some are fragile. So it will make a difference in removal. And then how many do you have to get out? So the easiest type of polypectomy is one in which a grasper can simply be placed at the base. These tend to be the pedunculated polyps, and can be removed simply by placing the grasper coming in perpendicular to the tissue. And the motion of removal is first extending the instrument slightly into the center of the uterine cavity, at the same time that there's a slight motion of the hysteroscope also toward the uterine cavity, and you get something like this. And always pushing away, being very mindful not to push too far, and also a slight movement of the hysteroscope to allow that tissue to be removed. And this is an example of that. This is a small polyp on the anterior uterine wall, just at the lower uterine segment. There's a little bit difficult access. You notice that the reticle is down, looking up at the instrument to allow my instrument parallel to the uterine wall. The grasper is perpendicular to the base, and the movement is toward the uterine cavity. There's probably not much movement of the hysteroscope with that. And then I can remove the small polyp. Very important technique is to turn the inflow of your hysteroscope off as you remove this tissue. Sometimes if the inflow is set too high, you'll wash your specimen off your grasper. Here's another polypectomy grasper. Again, these are the easiest type, and they're done with a pedunculated polyp. This looks very similar to the one that Keith showed you. Again, this is anterior attachment, grabbing the base perpendicular, moving toward the uterine cavity, extending the instrument slightly, and maintaining grasp. And now turning off my inflow, I can remove this tissue quite easily. This is the still that I showed you earlier. This is a postmenopausal patient. This is an adenocarcinoma, turns out to be, with multiple benign polyps. She did have postmenopausal bleeding. She also has uterine atrophy that was hemorrhagic. So she has a number of issues. My instrument is parallel to the uterine wall. This happens to be a very fragile tissue, so my movements are very small. I want to leave the pathology, if I can, if it's small, attached to the uterine wall. Notice there's not a lot of distension media flow here. There's not a lot of saline flow. I don't want to wash this away from me. I do want to turn off my inflow because it's fragile. I do want to use a grasper in this scenario because the tissue is fragile and it will actually hold a little bit better to that tissue. Fundal attachments are a little bit different. They're a little bit more difficult. And the reason is that we cannot bring our blade of our scissor perpendicular to the attachment. And we literally have to cut with the tip. So here is a scenario where you want to use a blunt tip scissor to avoid poking into the myometrium and causing discomfort. And you want to expose what you're about to cut. So the maneuver is to push down either with a closed instrument or an open. It's much easier to open the instrument. It creates more of a hand-like position to put tension on the polyp, separate it slightly from the uterine wall. It will identify the attachments for you. And then you can come in with the scissor, pushing down, cutting, pushing down and cutting. Again, the instrument is now perpendicular perpendicular to the fundus and the attachment. This is a postmenopausal patient. The endometrium is atrophic. This is a large benign polyp. It's been there for a long period of time. And we know this because they start to get the shape of the uterine cavity. This has a fundal attachment. So now if you notice the reticle is looking down, to allow me to see the attachment coming in. Again, the patient's awake, so I'm really trying to minimize my movements, be very focused. You have to start somewhere. So I essentially just start to transect the attachment. And after a period of time, because these polyps will obstruct your view, you literally have to push down, expose the tissue that you're going to be cutting. And that maneuver will work whether you are transecting a lateral attachment, a posterior, a fundal, or even anterior, is simply to push down, expose what you're going to cut. When the polyp is large, you don't always need to leave it attached because it's not likely to be floating away from you within the space of the uterine cavity, within the fluid. If you do leave it attached, don't leave it attached too much. I've also struggled with thinking that I can just grasp something and pull it out when it's still attached. Sometimes you get lucky. Sometimes the fluid will push the polyp out. Here I went ahead and grabbed it with that tenaculum, and now I can get the entire polyp out of the uterine cavity. Now, what about posterior? Posterior presents a little bit different scenario, and that is because the polyp can often really obscure your view, especially if it's big. I'm going to take you back to this this that you've seen a couple times now. So this benign polyp on the bottom, notice that the reticle is actually looking up instead of looking down onto the pathology, because looking down will, in a sense, limit the view that I get. So this becomes a little bit more difficult because I'm not seeing everything that I normally would if I were looking down at normal pathology. So I've got to change this just a little bit. So I'm looking up, so I get this angle of entry with my instrument. I will use some of the same maneuvers to identify the tissue that I need to cut. In this orientation, I just need to be very careful that I don't really dig into this posterior uterine wall. So right now I'm looking down at the pathology, and you'll see quickly that I'm limited in what I'm able to do. So here, this has been edited to show you now the reticle is rotated. Now I'm looking up. I don't see everything that I need to see, but I'm focusing really just on what's in front of me. Really wanting to identify with this maneuver what I need to cut so I don't cut too deeply into the space of the myometrium. Notice that this looks now like a lateral attachment, but my camera head is shifted. And this is just the perfect example to you that while I still can operate and I understand where I am, if I don't, then I think that I'm lateral, and I'm not, because the camera is disoriented now because it's rotated. Here is a perfect use of the tenaculum. It works better in tissues that have some substance, and the tissue is compressed. When the pathology is large, it does get more difficult to remove it. Turning off the inflow, I've already done. Sometimes a rotational maneuver can help to elongate the polyp into the uterine, into the cervical canal. And sometimes it's just better to be lucky than good. So I got lucky in that case because it was a big pathology for that cervical canal. Now, what about polyp size? It's very difficult unless you have a pre-procedure sonohystogram which you've measured with contrast fluid, the size of the endometrial polyp. It's really very difficult to estimate size because of the magnification of our systems. So these are my instruments, and I've laid them out on a ruler so that I know exactly, or near exactly, how many millimeters the separation is. So the tenaculum is a centimeter. So I know that when I hold that tenaculum out in front of my visual field, I can actually use that as a guide to estimate polyp and any pathology size, really. You can do this for myomas as well. So if you've got instruments, I recommend you just do this so that you can then facilitate estimation of size. Because when the polyp is very big and the opening of the cervical canal, if we're using an operative instrument, is 5 millimeters, this is much bigger. So then we have this dilemma of what will we then do to remove pathology? The most cost-effective way is to get very, very good with your scissors. And this will take, of course, more time than some of our automated devices. However, it can be done. One of the first ways to do this is to literally segment entirely the polyp. So you fully transect through the polyp. If you don't have to remove pieces one at a time, that's really great. And you also want to be able to cut pieces that you know can be removed through that 5mm cervical canal. So this is what I most often do with postmenopausal patients, simply because the canal is narrow and polyps grow big before they're detected when they're benign. And so you have to essentially cut it to remove it. Here's an example. Tissue density here really comes into play. This is a very solid cystic polyp. There is no way that this, if I transect it from its attachment, that I'm going to be able to get this polyp out. This is a bipolar instrument. It's called a Twizzle. This is a VersaPoint, originally presented by Johnson & Johnson or Gynaecare. It has come back onto the market through Olympus. I do use this in the office. For those of you that have Stewart systems, Stewart's does have a reusable bipolar needle, which is much more cost effective. It can be reused a number of times. I have used that instrument as well. It's a really beautiful instrument to have as a tool. And here, I'm not going to show you the whole thing, but essentially I need to transect pieces that are small enough so that I can get these out through the cervical canal. I can do this with scissors. If I didn't have this instrument, this would take a long time with scissors just because of the density of the tissue. And this might not be, if I didn't have this instrument, this might not be a polyp that I chose to remove in the office simply because of the time required with a set of scissors. The other option with tissue that's less dense and somewhat pliable is to not take the time to fully transect the pieces, because then each of those individual pieces has to be removed, and that will add time to the procedure. So if I can simply cut across the polyp, what this means is that at the time of removal, once I've transected it and I grab it, as I pull it into the cervical canal with a rotating movement, this elongates the polyp, and now I can actually get it through a very narrow cervical canal. And here's an example of that. This is a postmenopausal patient who had bleeding from a hemorrhagic polyp. I will make a decision to do this when my estimation of the polyp size really indicates to me that I may struggle to get a larger polyp out. I'd rather take a little bit more time. Here, it may be that my scissors aren't sharp, or sometimes just the tissue is so flexible that it's harder to cut through. Then so I've made a few cuts through the polyp or into the polyp, and now I'll come and transect. This is a fundal attachment and it's posterior, so it presents a little bit of more challenging case. My lens is looking up, because otherwise if I were looking down, my view would be obscured. This one I do leave slightly attached. This is an interesting tool. It's nice, but if the tissue is too fragile, as the 3 claws come back into the instrument, they sometimes transect the pathology, and so it's not very beneficial. So in some polyps, this actually works nicely. Rotate as I come through the cervical opening. So Attilio Dispiezio is really a master, and I learned this from him. So this is, I call this the Dispiezio-Sardo technique of removing a polyp. When you have a large pathology that is somewhat pliable, using the hysteroscope can really facilitate getting the tissue out. So the tissue is grabbed at the base, and it's first then pulled toward the hysteroscope, and you want to pull it flush, not like you're trying to pull it through the hysteroscope, because of course it won't come. Anything you pull through that channel will be removed simply because the operative channel is so small. And then you want to angle the camera slightly, and we're going to end up using the hysteroscope somewhat as a fulcrum to remove the tissue. So in a sense, you pull the tissue toward the hysteroscope and trap the tissue between the hysteroscope and the cervical canal, and then use that pressure to aid in removing the polyp. So I'm going to show you using that technique. You don't see all of the technique because the view is obscure. This is an anterior attachment, and the lower uterine space is really very difficult to approach because you have to angle the camera so much that it does put some pressure on the cervical canal, and so she may have discomfort. I've chosen to use my sharp scissors so that I can get a little bit more access to the anterior wall. I didn't show you the whole thing because really what I want to show you is the removal. Using the tenaculum, grabbing it at the most narrow end possible. So I'm going to pull the tissue toward the hysteroscope and pulling it toward the lens. And now here's the angle of the camera. And what you're not seeing is that I'm actually pulling the tissue out right now, using the camera as a fulcrum on the pathology to help me get a larger piece of tissue out. If you notice that I had to go back and get the tissue, that is okay if you can't get the full base at first shot. Sometimes the pathology itself is so restrictive to your visual field, you just have to get out what you can in order to see what you ultimately need to do to complete the procedure. So I went back, got the remaining, and then there's the end. Now, what about a fundal attachment? This is a fiber optic flexible diagnostic procedure. I know that this is very tempting. We've all seen this, and you want to put a ring forcep on and you want to twist this and remove this. Please don't do this in the office. And secondly, please don't do this at all. Put your hysteroscope in. The majority of the polyps that are coming through the cervix like that are going to have a very high intrauterine attachment. This one is high on the posterior wall, not quite to the fundus. This also has multiple finger-like projection attachments. So it's almost somewhat bilobed at the top at the attachments. This is a 3mm lens. So in a postmenopausal patient, I tend to start with a diagnostic procedure, make a determination of what I need to do. I actually do use a paracervical block. If this patient needed one, then I would do a paracervical block, dilate the cervix, and now I've placed my operative lens for this same patient. I didn't need to dilate her, by the way, because that polyp was coming through the cervix, created this natural cervical dilation. I'm using the bipolar electrode again, and here, because of the attachment, I'm using it really just in a very pulsatile fashion, trying to be very careful not to put too much energy near the myometrium. The polyp itself, she wouldn't feel this if I had scissors, but if I either lay on this electricity for too long or direct it too posteriorly, she will feel that, and it's uncomfortable. Otherwise, patients tolerate the use of the bipolar energy while awake very, very well with really just careful surgical technique. I could have done this with scissors. However, the more that I have to cut with scissors, I think Keith mentioned that the longer, the patient is awake during these procedures, it becomes a little bit more uncomfortable for her. So because this had such a broad and unusual attachment, I chose to go with this bipolar instrument. The easy thing about removal for this patient is that once separated, very, very often the fluid that is built up within the uterine cavity will just simply now push the polyp out. If not, it's very, very easy to grasp on the way out by simply putting a grasper near the cervical canal, grasping that polyp and pulling out. Here's a nice thing about having electrosurgery. This is using a desiccating mode now, is I can create total hemostasis. This bleeding would stop. As soon as the uterine cavity is not distended anymore, that bleeding does stop. Again, using it in a pulsatile fashion, the patient doesn't feel it. And now I've removed a large endometrial polyp in a postmenopausal patient. Here is a handheld tissue removal device. So this goes through a 5mm hysteroscope. So it is a 5 French instrument. It is attached to literally a freestanding suction device. And each time that blade rotates, that is a movement or a squeeze of my hand. So this can get very fatiguing. This is a postmenopausal patient. They had incidental findings of enlarged endometrial stripe. And this will ultimately remove this pathology, which was quite large. However, the cost of this device is about $500 US, which is expensive. And so it's not something that I would routinely use because it's, I think, really cost prohibitive. So once the benign polyp was removed, then there was some abnormal tissue on the anterior uterine wall. And just getting this down to the base. And now I can change the sock, and I had concerns about this tissue, which ultimately ends up to be atypical endometrial hyperplasia, which can look different from patient to patient. So that is a handheld 5 French tissue removal device. There are others that you might be familiar with. This is the TrueClear system. And this is a 6mm lens system. This is a dedicated polyp blade. This is not edited, the removal part. So of course these instruments are fun to use, they're efficient, but this blade alone, after the purchase of the system, which is going to cost, between about $20,000, each blade costs about $650 US. So it at some point is just not cost effective, and likely from the outset. There are times when it may be very reasonable to use it, but on an endometrial polyp, it doesn't seem reasonable when I can be very efficient with scissors, using other techniques to get tissues out, and not necessarily having to use these instruments. Most of what you're seeing, the companies are bringing instruments in to allow me to use. So this is much quicker than it would be if I segmented that polyp first before transecting it from the attachment. Here is another tissue removal device, and we're getting near the end. These are so common in these postmenopausal patients. I call them tongue polyps. They look like large tongues to me. They've been there for such a long time. You see the conformity of the polyp to the uterine cavity. The endometrium is atrophic. There's a left lateral attachment. This is a slightly bigger device. This comes through the last one that we saw comes through a 6mm hysteroscope. This comes through a 6.2mm hysteroscope. It is quick and easy, and this device is fully disposable and costs about $1,300 US. So again, very efficient, but becomes really cost prohibitive. So I've also had the pleasure of using the Stewart's 5mm bipolar loop resectoscope that you've seen, and it's a gorgeous instrument. If I could have any one instrument, that would be the one. It's so versatile. I can do so much with it. I can remove polyps and fibroids. I could use it as a diagnostic scope if I needed to, because it's so small. And I can't say enough good things about having that technology. You don't need it, of course. I think I've shown you some techniques that are outside of using these other technologies. And I am happy to answer questions. I could show you videos all day, but we don't have the time, and it's been a late day for you. So thank you so much. And if anybody wants to send me any questions or make any contact, there is my email. And again, I thank you for the opportunity to be here with you today, and looking forward to my time in Zimbabwe with you. Thank you.
Thank you very much, Amy, for the wonderful lecture. We learned a lot. This lecture should be probably given in the beginning of today's talk, but we were limited with the time, as Amy's 8 hours behind us. I have one little comment, that you I have to praise actually both of your lectures. It's quite often we do misjudge you. We do misjudge American medical system as highly consumer-orientated system. And you completely proved opposite today. You and Keith made it so easy for us, so affordable, and I'm sure more and more colleagues will be completely encouraged, not discouraged, by these lectures. Yes, indeed, several of these gadgets are beyond our reach, in particular through CLEAR. Even number of these procedures, interestingly, you managed without the shaver. So it looks, I'm sure it's looking much more accessible to all of us. Any questions?
Let me make one comment while maybe people are either waking up and thinking about some questions. Is that I want to echo what Keith has presented, and really to encourage you to pursue office hysteroscopy. It does not have to be as expensive as buying a $40,000 system. That you need good visualization, and the telepack that Stewart's has is really a very beautiful option because it gives you everything that you need, and you don't need a procedure room. You can do this in an exam room, and you can reuse these instruments over and over and over and over again. And it doesn't take that many procedures to really, you know, get these this investment to pay off financially. So, you know, your investment can be half of that, if not less. I started my first systems with a refurbished system, or my first procedures in my office with a refurbished system and hysteroscope. So it is possible to do these in a really cost-effective way. And please, and the technology is great, and it's amazing, and it's fun, and it does create some efficiencies, but it's not necessary, and you can get good with your operative instruments. So I would encourage you to really explore that, and don't get turned away by the cost.
Thank you very much. We have two questions. Dr. Eaton Vuma, it's our Zimbabwean, who is a very popular gynae in Johannesburg in South Africa. Eaton. Eaton. There is another question. Someone else raised the hand.
Hello.
Felix. Oh, Eaton. Yes. Okay. Yes.
Okay.
We are listening.
Thank you for a wonderful presentation, Emmy. I just wanted to find out, would you recommend this, for example, for the retained product of conception, the telepack, instead of doing a straightforward evacuation?
Oh, yeah. So you're asking to do procedures under visualization?
Yes, for retained products of conception.
Yes. So absolutely. And you don't need a tissue removal device. Again, it makes it very efficient to use one of those. However, you can remove even if it were, you know, using your resectoscope loop and using it cold, or simply using your scissors and graspers to separate tissue under direct visualization. And I think that we're finding more and more that removing the retained products without visualization is creating significant astromens. And so I think we're significantly traumatizing the tissue because we're doing the procedures blind. And that if more of the removal were done under direct visualization, we would see a lot less of that. Does that answer your question?
Yes, it does. Thank you. Thank you.
Yeah.
Another question from Felix Mitlanga.
Yes, thanks, Amy. This one is just an academic question. Do you think in terms of scientific endeavor, it would be possible to get instruments that are usable bimanually at hysteroscopy?
Give me a little bit more detail.
Sometimes you take a small piece of tissue, you could hold it and cut it. But do you see that as a feasible option in terms of development?
I see. So you're talking about technology that you insert into the uterine cavity and you operate it much like the robot. It's basically robotic, and you've got 2 instruments that come into the visual field, one to hold and one to remove.
Correct.
Yeah. So, you know, I've thought that that is very interesting technology. I think that when you're talking about a $250,000 system, it's almost laughable. And I would say that it's not necessary, that you can, would it make it easier? Maybe, because there's a little bit, you know, the space between the holding instrument and the operating instrument is actually very small. But does counter tension help to cut? Absolutely. So there is a particular physics there that makes sense, but the trade-off for the expense down the line, I can't ever see something like that being cost effective. Not only for the system and then the per case expense to remove a polyp, it's really laughable. So you can get good with scissors and graspers. And I think it's about understanding the tool that's in your hand. You can practice. You basically take some duct tape and you strap a bell pepper to your exam bed, and you use your own system, and you practice and you practice and you practice taking out seeds, transecting the vegetable, and you don't need saline to do that. And you get really good at understanding your lens instrument relationship. And I think that something like that is just not ever going to be necessarily, and certainly not attainable. Does that answer your question? That's my opinion.
It does. I was actually also thinking that, you know, sometimes if you've got something that can cut and suck at the same time, maybe there's not so much, you know, need to go in that direction. But I've always wondered why that hasn't happened before we got these true clear and, you know, these Storz versions of it. Because
you know what, it would be interesting. I see what you're saying. Like, are you saying
maybe it gets better, but
like even a syringe?
Yeah, something that will give you contraction, something that can suction, something that can pin something to the side and you cut and doesn't float away. But I didn't see in the literature any attempt to develop something along those lines. Maybe because these cut and suction came along, and I don't know. I just
no, Felix, I think that is a great idea, and there is nothing. And when you think about the suction that we use to remove you know, products of conception and missed abortion, you know, we're not using that high really of pressures to do that. We're using, you know, 6 millimeter cannula. So could we create something that really was giving us some visualization and using suction? I think that's a good reason for me to come and work with you and to come and visit, and we'll figure out if we can, you know, use that idea. But I think it's a great idea. There's nothing available that I'm aware of that would do that for us outside of the suction, you know, systems that are with these tissue removal devices, which, as you know, are just expensive. You know, I think that
thank you, Amy. We can raise some funds to.
Yeah, we'll raise some funds. You know, I think that if you happen to have one of these systems because you're doing a lot of either terminations or, you know, missed abortions in an outpatient setting, you know, when you think about maybe those large polyps, once you transect them, could you then put in a 6 millimeter cannula and then use suction? I think it's not unreasonable, and likely it doesn't pull the polyp fully into the cannula, but it would likely hold on to it well enough to pull it out. So I think if you're in an operating room environment, I've certainly never tried that in the office, because to get a 6 millimeter cannula in and dilate to 6 can be difficult, especially if we're a postmenopausal patient. It's just too much. So, you know, the difference between that 1 millimeter difference really is a lot. So I think that that's not unreasonable to try. I've just never been in that position to use that.
Thank you.
Sure.
Thank you very much. We have Dr. Ngorora. She would like to pose the question. Dr. Tina.
Yes, hi. Before I ask my question, for the Zimbabweans and South Africans listening, bell peppers are green peppers.
Oh, I'm sorry. A green pepper, yes.
we, yeah.
We actually they come in other colors, you know, yellow and red and purple and
green,
orange.
Yeah. So Zimbabwe, when someone talks about a green pepper, that's what she means when she says a bell pepper. So Dr. Garcia, I would really like you to clarify this point, because this question keeps being raised throughout the whole, so far it's been asked many, many times, and there seems to be some confusion. When you say resection or retrieval of retained products under direct vision at hysteroscopic removal of retained products, you are not talking about management of a miscarriage. You're not talking about a woman who presents with a miscarriage at 10 weeks with retained products. You do not put a hysteroscope for that. What do you mean? Because I think what's the confusion that's coming through is the use of the term retained products for some people means anything that's a product of conception in the uterus, i.e. 10-week miscarriage, miscarriage. That would not be appropriate for a hysteroscopic procedure, would it?
I think it's really important, and I've never been on the end of that conversation to make the clarification, but I think it's a very important clarification. So yes, you are absolutely correct that during a miscarriage, active miscarriage scenario, that you're deeming it necessary to remove products so that the patient stops bleeding is not likely the scenario that hysteroscopy is going to be useful. There's just too much bleeding, you can't create distension, it's a pregnant uterus, you're gonna push a bunch of fluid into the uterine wall, you know, just the vascularity. This is just not the scenario where hysteroscopy is reasonable. So you would use your suction technique in that case and remove the tissue like we normally do, and be careful about the endometrium. When we speak of retained, I think the general assumption is that the patient has had a pregnancy and delivery and products are still there, or she has had what she believes is a completed miscarriage and products are still there. So there is a time delay between the pregnancy and the time that we will go back in and remove products. So much so that if the tissue is still too vascular and she is bleeding, but not excessively, you may give her a bit more time. And simply because unless you're planning to use electricity to go back in and remove these products when there's a significant amount of vascularity, I think it's going to be really quite challenging unless you do it with direct visualization with a loop, and you can be very judicious about your electricity use. So the retained products then is this period of time when there's very little vascularity, to do this under direct visualization and to minimize the tissue trauma that we know that we create when we do these procedures blind. And so I think that for the majority, when we say retained, we're really talking about a period of time after the pregnancy. Is that helpful?
Yes, thank you. Yes, that was my understanding of where you would use this. Oh, sorry, my kid was going.
Yeah, and imagine if you choose to use a tissue removal device in a scenario when it's just too soon to, unless it's needed, then you know you do make these decisions. However, you just have to understand the bleeding that will ensue if you're not giving her enough time to allow the vascularity to change.
So in my practice and common practice in New Zealand would be when a person presents with a miscarriage, the options would be either medical management, expectant management, or suction curettage. And only if then someone had persistent products, and usually you're looking at a few weeks down the line, so 4 or 6 weeks down the line with, you know, still having products and still having products seen on ultrasound scan, would we then put the hysteroscope? And oftentimes these women would actually present maybe via fertility, where they've been trying to conceive and they haven't conceived. We do a scan, we find something. Beta HCGs by this time are actually negative.
Yes, so I think that clinical scenario that you just expressed is, I'm in 100% agreement with. And those are the scenarios that you will see the retained products, or you start to suspect it, that 6 to 8 weeks after she's delivered, she still has abnormal bleeding. You do an ultrasound and you see products in the cavity, and it is a cause of infertility. And so it's the same scenario. Usually you've got a little bit more time between the last delivery or the pregnancy when they're infertile, but it's the same exact scenario that you described. And the same management is what I would do as well.
Thank you very much for your question. It was a really interesting question, and we were battling throughout the day. We had various comments. I do have one comment regarding VersaPoint. I still do miss that instrument. This is mostly Storz orientated market. Yes, I did try. Yes, sure, that bipolar needle, but VersaPoint is VersaPoint, and I do miss it. Unfortunately, I will have to get used to bipolar needle. Dr. Felix Matlanga has another question, or that hand remains standing. Felix? No, not at all. Okay.
Can I respond to that, Dragana? It's yes. So Olympus is bringing that instrument back. So you may actually keep your generator. They will start to make electrodes, and I think that this is an important point. Is that Karl Storz is an amazing company, and I've worked with them for some time, and I think that their dedication to the quality of instrument and to patient care is really unmatched. But I also think that we use what is best for us, and we use what is best for the patient, and they know that. And they don't, I don't think we're all here to, we thank them for their contribution all the time, simply because they're furthering hysteroscopy. And whether we use their instruments or not, they are committed to providing us educational platform to really do better for patients. The nice thing about the VersaPoint is that it's basically a double braided, and so it's a little bit thicker than the needle. So it does feel a little bit more versatile. And like you, I'd like the needle. It's good and it's reusable. And I think that we do like we do in medicine for all things, is that we're going to put our experience together with the access that we have to technology, and then we're going to do the best that we can within that. And so I just wanted to say that, and I think Storz would be okay with that, I hope. And then go ahead, I'm sorry.
Yeah, I'm sure they forgave us harmonic, LigaSure and VersaPoint. They have to forgive us, but they have to work on developing their beautiful instruments. And yeah, they're really the leading company in the world. Thank you very much. Please, everyone feel encouraged. We had, as I said, number of senior consultants, professors from 3-4 different continents. I'm very proud the meeting went very well. I think number of younger doctors that are watching this are inspired. And please feel free. Amy seems to be very friendly, so we must abuse her and send her messages. Not at all, but we should keep in touch with Amy, and looking forward to have her with us here operating. And also, please do feel free if you have questions regarding equipment, what you should think of purchasing or taking a loan to purchase, or at least to get in touch with her to get her experience regarding the various instruments and equipment that she presented today.
And I'll
you very much.
I'll put my email again in the chat if anybody wants to get that.
Thank you for that. I'm sure I didn't mention that Professor Isaacson is on the same boat. He's our old friend, and if anyone wants to get in touch, more than welcome. Dear colleagues, it is our short closing remark. We as ZSGE in conjunction with the ZSOG, want to express our gratitude for your participation and active involvement with today's symposium. We as both societies are in challenging situation due to the current COVID-19 outbreak in the country and worldwide, and additional difficult economic situation in our country. But we won't stop striving to move on with time in our specialty, adopt and master new techniques and new technologies with only one aim: to improve Zimbabwean women's health, regardless of various obstacles which we mentioned today. It was my pleasure having you with us, and I do hope this is not going to end here. We will strive to have more meetings like that. Warm regards from ZSCG and ZSOG team. Cheers.
Thank you. Thank you.